Yeah, that was Madam was telling.
Uh,
Very unfortunate.
hmm.
So sudden.
We have to all be careful.
That was Madam.
And
Abhishek?
We are live now.
Okay. Can I start now?
Yes, ma'am.
Yes. I, Dr. Monica Vardhan. I am the coordinator for Public Awareness Committee programs. I welcome you to the 10th episode of Public Awareness Committee webinar series with the South Zone Societies. Abhishek, please call Kamini ma'am. She's calling me. With the West Zone Societies, and the topic that we have selected right now is infertility in view of June being an infertility awareness month. We have also taken environment into consideration because 5th June is celebrated as Environment Day. So we've kept the talk as environmental factors affecting infertility to address the same issue. I am eternally thankful to Pai sir for being present always at all our events. We begin with taking the blessings of Lord Almighty. Can we have the inauguration slide, please, Abhishek?
सद्गमया तमसो मा ज्योतिर्गमया मृत्युर्मामृतं गमया ॐ शान्ति शान्ति शान्ति.
Thank you. I request you to please display the slide of Pai sir so that I can introduce him formally for this webinar.
Yes, ma'am.
Sir is currently the president of FOGSI, and he is always been approachable to almost all FOGSians who need help. We welcome you, sir, to the 10th episode. He is the administrator of FOGSI Manyata Initiative. He is also the director of Corporate Affairs, IFS, International Federation of Fertility Societies. He is an adjunct assistant professor at Eastern Virginia Medical School, USA. He is also a postgraduate teacher at DNB Examination India. No introduction is enough, sir, for your academic accolades. I request you to please bless this webinar now.
Thank you, Dr. Monica. I would like to congratulate first the Public Awareness Committee Chairman Dr. Priyankur and the Adolescent Committee Chairman Dr. Supriya Jaiswal, and we have got our stalwart Dr. Sampath Kumari, who is busy arranging her, the Kodaikanal conference, and the other stalwart, I think Alka Pandeyji is there or not? I can't see her. Anyway, and then there are a lot of my friends who are there. Dr. Rekha Rajendra Kumar is there, busy, making the preparations. Then Dr. Narsimha Reddy, my very old friend, is there for many, many years. Then Dr. Bharti Rajsekar, Dr. Jairani Kamraj is there, Dr. Archana Singh, Dr. Kalpana, who is also making her preparations. So there's a lot of people who are very actively working towards their careers, and I wish you all the very best. Ultimately, I always feel that the chairmanship, when we were chairman, that were 5-year duration. Now it has been reduced to 3 years. So all of you ultimately will achieve the goal. So you have to keep on at it, and ultimately you will achieve your goals and go further in your achievement. So I wish you all the very best, all of you. And this on the World Environment, the other day I was called by the Lung Care Foundation into New Delhi on the, I think I went few days, I lost my touch when I'm going where. But it was a very nice gathering because all the presidents were present. The National IMA president was there. Then our National Surgical ASI president was there. The Pediatric Secretary General was there. The Cardiology Association president was there. The Endocrinology Association. So nearly many presidents were present, and we all were, air pollution and all was the main theme topic of the whole gathering. And the FIGO also has got a declaration around 2015-16 on environment and what we can do. But when they told me, Dr. Pai, you tell us what FOGSI is contributed to the air pollution and climate. So I told them, of course, Dr. Kalyan Varmade is not there, but one of the main activities of FOGSI has been tree plantation, and I have told Kalyan that this year he should plant one tree for every 1,000 deliveries. So we were going to plan that we'll divide the 30 million deliveries into 266 societies and make all the societies plant the trees based on the number of deliveries in their region. And I met Kalyan the other day, and he promised me that he will start doing it from the rainy season, from this month onwards. So let us look forward to it. The second thing I told him that we are also actively doing family planning. So, biggest problem to contribute towards environmental problem is the family planning. The number of people has gone so much in our country. We have even crossed China. And if you see the size of China is 3 times larger than India. So our density of population is more than 100 per square kilometer compared to China, where it is around 30 per square kilometer. So the pollution levels in India are tremendous. The water bodies are all full. And because of that, there is repercussions in various fields, including infertility. We have higher incidence of cancers also because there is a contamination of the soil and the water body. So one of the important things we need to do and which we are doing as FOGSI, and welcome Dr. Kamini Rao, also our stalwart. So what we need to do is that we need to actively control family and do the family planning program. Maybe reversible contraception, maybe implants, maybe oral contraceptive pills. A lot of new pills are coming in the market. So in our own small way, what is related to our profession, what we can do is, of course, planting trees and all other things that are important, but they are not related to our profession. What is related to our profession is to get the population down, and that we should do very aggressively at all the society levels. And that can be done by awareness campaigns, advocacy, etc., etc. So I don't want to get into the nitty-gritties of it. I would like to again thank you all for calling me and wishing you the very best for a very fruitful session on both infertility and pollution and environmental contaminations, etc. Thank you for calling me for this function. Thank you.
Yes, sir. Thank you so much, sir, for your blessings, as always. I would now like to also thank the Adolescent Committee FOGSI, who is also our partner in this webinar. And I would now request Dr. Supriya Jaiswal, ma'am, to introduce our guest of honor, Dr. Narasimha Reddy, sir.
Thank you, Dr. Monica. It is my privilege, really, to introduce Dr. Narasimha Reddy, sir. Sir is past president of Telangana Council of OBGY Societies and then professor of OBGY Pratima Institute of Medical Sciences, Karimnagar, Telangana. He is a stalwart of FOGSI, and with these words, I welcome you, sir, and over to you.
Yeah. Good evening, everybody. Good evening, Paisu. It's a wonderful occasion for me to participate in this webinar. So it's a public awareness committee. Dr. Priyanka Roy and Jaiswal madam have taken an initiative to do it. As Pai rightly pointed out, this environmental factors are influencing every part of every incident, everything in our life. Not only infertility, whatever every aspect of our life has been influenced by these environmental factors, as well as the rising population. Of course, at our place, few of our gynecologists are doing us right. Boy has said rightly, we are giving a plan to the mother when she leaves the hospital. Once the baby is born, we are giving a plan. Of course, that may be a little gesture on our part, but the thing is, the government and the bodies, including FOGSI, other associations, have to take an initiative to curb the pollution. Of course, central government has taken a right step, in the form of Swachh Bharat. Definitely, at our place in our Telangana, it has revolutionized, madam. because I am right now at 60 plus. When I was a child, of say 10 years old, there used to be a lot of dirt around around our house and in the vicinity. But right now, most of the roads and everything are fine. But the as a gynecologist, I always start asking the patient, what is your profession, where you do live, whether this man is exposed to any of the toxins. First I will educate them, especially males. I don't know much about the influence on the female, but definitely the male has got male being influenced by these external factors much more than females. I think. Good evening, Kamini madam. So this is a very good initiative on your part, madam. Best of luck. I don't want to take much of your time. Can we have 1 minute of silence as a mourning, for the departed soul, if the organizers permit us?
Dr. Monica?
Sure, sir.
Thank you, madam.
Thank you,
You can
sir,
go ahead.
Thank you so much, sir, for joining us and blessing this episode of Public Wellness Committee and Dawson Committee program. I would now request Dr. Shatabdi Dey as coordinator for Public Awareness Committee to introduce our next guest of honor, Dr. Kamini Rao ma'am.
A very good evening to everyone. It's my utter privilege to introduce Dr. Kamini Rao ma'am. Ma'am, as we know, is the medical director of Milan, the Fertility Center. Ma'am is also the chairman of the National Registry of ART Clinics and Banks in India from 2018 till date. She has been the past president of FOGSI as well as ISAR. Ma'am has been awarded with the highest award for civilians in India, that's the Padma Shri Award by the Government of India in recognition of distinguished service in the field of reproductive medicine in 2014. She has over 50 medical textbook publications as well as 41 publications in both national and international journals. It's our privilege to have you here, ma'am. We would like to hear a few words of wisdom from you.
Thank you very much for inviting me to be the guest of honor here. And it's my pleasant task to talk about infertility with pollution. Of course, pollution is a global phenomena. It is not only related to infertility. And I'm sure Rishikesh and my other colleague have also spoken about it, and a fair amount of what they have said has been will also be echoed by me. But more importantly, the burden of pollution and of eradication of pollution has to be on each individual. It cannot be only a government responsibility. And I think, when we look at it, each of us have to do our bit. And if we all put our hands together and say that this is what we are going to do, it's like every drop makes an ocean. And it's the same thing that will happen, in our country. Because how is it that people who go from our country, Indians, and when they reside in the UK or they reside in the US or in, say, Scandinavian countries, Australia, they don't put rubbish on the road. But the moment they come back to India, they feel that this is their might and right, and they start putting the rubbish on the road. So it's only an attitudinal problem, which I can actually fathom. So it is the question of discipline and self-discipline. And if we do this, then our children will follow. And if our children follow, then, the entire family, and then a chain reaction is set up. So apart from that, of course, we know with a lot of this pollution, infertility also goes up, overcrowding, and a whole lot of sanitation problems. So clean water, clean air can solve almost 30% of our health issues. And that is what we should aim for. So if we keep the environment clean, and we find that a whole lot of respiratory problems also will come down. In fact, Bangalore is known to be the respiratory capital for respiratory infections of the country. And this happens only because of so much of pollen and a lot of dust and a lot of mites and a lot of the pollen that comes out. So I'm sure you'll understand that each one of us, it's not only the doctors, it is the citizens of the country, have to participate in this, either whether you talk about planting trees or making sure that we don't throw garbage around, or we make sure that if anyone else throws garbage, we should make sure that they do not do it and teach them that this is not right. Because it's being a passive spectator to all this in itself is bad. Why should I tell them? Because, anyway, it's not my house. That attitude should not be there. And I hope that one can internalize this responsibility of taking this pollution to the doorsteps of each and every person. It is a responsibility of every citizen of the country. And I hope that whatever you're going to talk in this particular seminar will echo the same thing across every lecture, because once we keep on talking about it, then it becomes a rule. So any amount of government rules or regulations or law cannot be fruitful unless it is implemented in the right way. And the implementation has to come from within us. So with these few words, I thank you all for giving me this opportunity to say these thoughts that I had, and I wish this webinar a great success. Thank you very much.
Thank you so much, ma'am.
Thank you so much, ma'am, for your blessings. Over to you, Monica. Yeah.
Thank you, ma'am. In the lines of what you have already said, ma'am, we have arranged a slogan writing competition on the occasion of International Menstrual Hygiene Day also, ma'am. And we were overwhelmed with more than 100 entries, ma'am. And Dr. Supriya Jaiswal, ma'am, has consented to be the judge for the same competition. We take pride in announcing the results for the same right now in the presence of esteemed faculties like you and Reddy sir and Pai sir. Jaiswal ma'am, can you please declare your results and also let us know how it was judging this competition, ma'am?
Yeah, thank you, Monica. So it was a pleasure, actually. We were not expecting such huge response, but all of them had done their best. Whoever had their mindset, what they thought about the pollution or whatever. So they put it into slogan form. Somebody has, it looks like they have written by themselves. So it was very difficult to decide, actually. But then there was a tie also in one of the slogans. So I have finally made up my mind. I gave the results. And if you just show me, Monica, I'll just declare it.
Ma'am, we will be displaying the third prize first. All those who have participated are already the winners. So congratulations, everyone who has participated in this competition.
Yeah. This is Dr. Madhu Gupta. She was from Bareilly and she has got the third prize. संकोच की बेड़ियां तोड़ो, मासिक धर्म के ज्ञान के मोती जोड़ो, बिटिया रानी क्यों है झिझकती, ये तो है प्रकृति की शक्ति. This was the very nicely written and it was like she wrote from her heart, looks like. So she wins the third prize. Then Dr. Anita Rajoria from New Delhi, she wrote स्वच्छ नारी स्वस्थ नारी हेतु सतत मासिक धर्म उपायों का चुनाव नारी प्रजनन स्वास्थ्य के लिए लाना है बदलाव. So she won the third. So congratulations, Dr. Anita Rajoria. Now comes the second prize. This was won by Dr. Mamta Gangwal. She wrote महामारी के वो दिन अब हमें नहीं सताएंगे, जानकारी, सफाई और कसरत हमें बीमारियों से बचाएंगे. So this was her prize. So congratulations to Dr. Mamta Gangwal. So Dr. Suvarna Bhopale, she won the second prize again. महावारी को न मानो परेशानी, ये है नारी शक्ति की निशानी. स्वच्छ रहो स्कूल जाके, सब काम करके, निडरता तुम्हें है दिखानी. पुरानी रीत को तोड़ दो, ओए ए बिटिया, ए मेरी बिटिया रानी. So this was hers. This was also very well written by her. So this is Dr. Suvarna. You also have huge congratulations from all of us. So coming to the first prize, Dr. Taru Chaya from Jaipur. She wrote स्त्री और पर्यावरण अगर दोनों को बचाना है, ग्रीन पैड और कप को अब उपयोग में लाना है. Dr. Taru Chaya, and her presentation was also very nice. A huge congratulations to you and huge round of applause for the winner, the first prize, Dr. Taru Chaya. So let us congratulate all the winners and thank you very much and congratulations to all who participated in this slogan competition. Thank you very much. Over to you, Monica.
Thank you so much, ma'am. We also want to inform that each of these participants as well as the prize winners would get their certificates online. The prize winners get prizes sponsored by Corona Remedies. The first prize is a watch and the second prize is a fetal Doppler. So they will reach them physically also. Also, in lines with the same, we have launched another competition, each one plant one on the occasion of Environment Day. And those results would be declared in the next webinar on the 29th of June with the East Zone. And the judge for the same would be Dr. Alka Pandey, madam. So I hope each one of you would be able to participate because it is only planting one plant on one FOGSI member. So each one takes the onus for themselves. We will be improving the environment in a long way. I now declare that the inauguration is over. Thank you, esteemed faculties, Kamini ma'am, Reddy sir, and Pai sir for joining us for the inauguration. Thank you so much. I now take the academic session forward. Let me introduce the chairpersons for the first session, Dr. Subhash Malya sir and Dr. Supriya Jaiswal ma'am. Dr. Subhash Malya sir is a member specialist board of National Board of Examination and Minimal Invasive Gynecology. He is the chairperson of Medical Legal Committee KFOG and the secretary of the Calicut Society 2020 onwards and the Kerala chapter of IAGE. He is also the managing committee member of IAGE and the FOGSI Mentor-Mentee Awards 2019. He is also the treasurer of IMS Calicut Society. We welcome you, sir. Our next chairperson for the session is Dr. Supriya Jaiswal ma'am. She is the vice president of Patna OBGY Society and the chairperson of Adolescent Health Committee FOGSI for the year 23-25. She is also the joint secretary of SOCI Bihar and Jharkhand chapter and the chief consultant at SM Hospital Patna. She is the executive member of Central ISAPAC as well as
Monica.
the executive. Yes, ma'am.
Thank you. Thank you.
And you can go ahead with the session with the introduction of Sampath Kumari ma'am.
Yes. Thank you so much for your kind words of introduction. Thank you. And it is really my proud privilege to introduce none other than my ideal, whom I really follow, Dr. Sampath Kumari madam. Madam is professor and HOD, OG, Sri Mathukarama Medical College and Hospital. Madam is at present Vice President of FOGSI, Senate member of TN Dr. MGR Medical University, National Corresponding Editor of Jogi, Founder Secretary Tamil Nadu Federation of OBGY, that is TNFOG. Madam is retired by Director, Institute of Obs and Gynae MMC Chennai, President Board of Studies OGTN Tamil Nadu, that is Dr. MGR Medical University 2015-19. Madam has been the chairperson of FOGSI Adolescent Health Committee in 2016-18 when she had also visited Patna
Supriya.
during that time.
We'll stop with adolescent committee.
Oh, yes. So over to you, madam, thank you so much for being here. Over to you, madam.
Thank you, Supriya. I'll share my screen first.
Yes.
Yes. Thank you, Supriya, for the nice words. First of all, I congratulate the Adolescent Health Committee, so Chairperson Dr. Supriya, and the Public Awareness Committee, Dr. Priyanko, for the wonderful series, and the Dr. Monica for the continuous efforts. She is doing all the programs, I think, and the convener, Dr. Bharati Rajshekar, and the entire team. The topic given to me is environmental factors affecting the male and the female infertility. Now we had the environmental day, and the menstrual hygiene day was also on May 28th. So the infertility, as all of us know, it affects millions of people, and it has its impacts on the families and the communities. 1 in every 6 people of reproductive age worldwide experience infertility. The problem being the male ejection of the semen, absence and low levels of sperm, abnormal shape, and the movement of the sperm with the male factors. And the female being the abnormalities of the ovaries, uterus, fallopian tube, and the endocrine systems. So infertility on rise, is it alarming? Definitely yes. See, the use of assisted reproductive technology, ART, by infertile was increasing from 5% to 10% per year. In 1950, there was average of 5 children per house. Every woman used to deliver about 5, 6, and like that children. And an average of 2 children in the year of 2010. Then what happened? Again, the incidence of infertility is increasing. This is the FOGSI filters in the US. What he is telling, there is the long time decline in birth and the fertility rates. This is mainly because of the multiple factors. Higher educations, career opportunities for women, late marriage and access to contraceptions, delayed childbearing, and decreased family size. These are all the reasons which produces. So this is the situation with 1950s, and now this is the situations, the latest situations. So what are all the environmental factors? Though we have a lot of factors, we, as you told, male and the female factors, the environmental itself is producing the infertility. See, the epigenetic changes, alterations to the way the genes work, caused by the environmental and the lifestyle factors, could be the cumulative across generations. Then the chemicals, the plastics and the household medications in the food chain and in the air, that is the air pollution. Now we have seen the talking by the Kamini Rao's madam also. It produces the infertility. And the black carbon, chemicals, phthalates have also been found to reach the babies in utero. Pregnant women, when they are used, the babies will produce the complications. Again, the lifestyle changes, poor diet, sedentary lifestyle, stress and alcohol and drug abuse. These are also the causes for the infertility. Again, the climate, again, you can see this climate change may also negatively impact male infertility. That is, the heat waves has been shown to damage the sperm. That we can see a lot of slides in about the end. The 2022 study, it is found that high ambient temperature due to the global warming or working in the hot environment negatively affects the sperm quality. These are all proved. These are all the literatures which tells, see the environment here. The air pollution significantly impacts the human fertility. See, this is the road which travels with the pollution. Definitely it will affect the semen quality, primary predictor for the male fertility. And it is about the environmental pollution affects the sperm quality by impairing the process and leading to the decreased male fertility. On the female side, again, increased risk of menstrual cycle disturbance, dysfunctions, and irregular periods. They are also affected by the ovarian aging. So this is the pollution, where this is a study with the China. The China, they have told that the air pollutions, the incidence of infertility has increased. See, the common levels of nitrogen dioxide are as bad as smoking, is rising in the risk of the miscarriage, and the pollution particles have been found to the fetal side of the placenta. So the small particle pollutions, that was 10 micrograms per cubic meter, higher over a year to 20% greater risk of the infertility. Now the average pollution level, if you see the Chinese couples, it was 57 microgram. In London, it is 13 microgram. So the study with the dirty air and fertility used data produces the poor sperm quality, and which produces the negative impact, air pollutions. So while there are certainly steps that individuals can, what we can do to reduce the exposure, such as air filtration system and keeping the area clean. Only area when the air was very clean, all of us we know during the corona period, everything, the pollution was free and the disease would have increased. Though the COVID was increasing, the pollution was very, very good. The environment was good during the corona period only. The pollution particles are known to cause inflammatory in the body, that is the damage the egg and sperm production. These are all by the scientists. The another study which tells increased exposure to air pollution associated with lower number of maturing eggs. This is the air quality index. What does this air quality index tells? The rates air quality on scale from 0 to 500, with 0 being the cleanest and 500 being the most dangerous. Almost in all places, it is around 200 to 300. So the ground level goes on, it has completely changed and the air quality index is disturbed. See, we can live without food for 30 days and without water for 3 days, without shelter for 3 hours. But without air, we cannot live even for 3 minutes. Since this air pollution has to be taken care. See, these are the Yamuna River when it was before and during the corona period. See how it is clean. And all the places, you can see the Taj Mahal, India Gateway, everything during the corona period, the full clear view has been seen because of the pollution. So the air pollution is the important factor which all affects the quality. This environmental factor, what it is, the journal, what it states, that is National Institute of Environmental Health Sciences. Healthy conditions for egg cell maturations are important for the egg to properly generate the proteins, which is very, very important. That is the thankyrase, and promote the success of the embryo development. This is the quotings by the Williams. This is the way how this thankyrase is useful for the embryo development. So coming to the environmental factor, what are all the factors? Physical, biological, behavioral, socioeconomic, and chemicals. Physicals, if you see, the enzymes required for production of sperms are sensitive to heat. Men who are working with hot tubs and wearing tight pants and sits in the desk all day and stand in front of the hot stove, that is during the ironing work, it causes heating to testicles and it can produce the disturb the sperm. And the testicle should be at the 4 degrees cooler than the normal temperature. And the weight, again, if it is overweight, the body fat levels more than 10 to 15% above normal can overload the body with the estrogen and disturb the reproductive cycle. Similarly, the underweight, that is 10 to 15% below normal, can completely shut down the reproductive force. So the lifestyle modifications, diet and the exercise is very, very important. And the biological, the environmental virus, the HPV virus, as all of us know. Now also, sir, we had that launching of the HPV virus project last Tuesday with Dr. Priya Ganesh Kumar Oncology Committee in Mumbai for HPV vaccine to all adolescents. This HPV virus, again, it produces the genital cancer, which is also one of the causes for producing. The behavioral, now the stress starts from adolescent and it goes on. The stress-related disorders in women are chronic anovulation, pseudocyesis, menstrual dysfunctions, early pregnancy failure. In the men, it is decreased sperm count, motility, morphology, impotence, and the ejaculatory disorders. Stress, again, which I told, it increases the male and the female factors, which in turn produces the infertility. So this stress leads to the oxidative stress, sperm DNA damage, number and motility disturb, male infertility. All with this, these are all other factors which increases the oxidative stress. Socio-economic, that is poor and hygiene, that is entirely different. Again, the habits, habitual smoking, cigarette smoking contain toxins that are blamed for the bad effect on the male health, which in turn, it reduces the decreased fertility, sperm morphology, motility, DNA, sperm concentrations. So the damaging sperms genetically and imbalancing the hormones. These are all the habitual habits. So as per studies conducted, the success rate of IVF and ICSI were 22% in couples who had habit of smoking, whereas it was 38% who didn't have the habit of smoking. The chemicals, as all of us know, the endocrine disruptors. This is a molecule that mimic the body's hormones and throw off the fragile hormone balance of the reproductions. That is the phthalates and the plasticides, the pesticides, herbicides, heavy metals, toxic gases, and synthetic material. They are all producing the harmful effect with the human fertility. There we can see the male fertility is affected and the female fertility is also affected. These are all the chemicals, benzopyne, BCP, dioxins, Yeah, that is the reason we tell that the menstrual hygiene day, always we talk about the pad should be given in the incineration and it should not be thrown out. I think Supriya has given the picture for the slogan first. That is where the pads are also seen. That is the pollution. So the pesticides, DDT, DE, dichromophen, lead, all these factors produces immaturation of the oocytes, developmental abnormalities, potential change in sex ratio, or DTT producing reduced parity, impaired lactations at all level, the infertility, the chemicals producing the disturbance. So the reproductive toxicants, as I told, effect on the male with count and morphology. These are all the examples. And there are studies which tells that effects of particulate matter, exposure and semen quality. A retrospective cohort study which proves that the semen quality is disturbed. Similarly, with the ambient air pollution male, a retrospective analysis of the longitudinal data in the China, which tells that the pollution affects the fertility effect. These are all the 90-day, what are all the problems, 90-day average concentration, what happens with the ozone layer, the disturbance of the pollution with the ozone layer leads also to the fertility. So the occupational exposures which producers are at risk. Similarly, the female infertility, all factors with the environmental, the tubal factors, ovulatory factors, endometriosis, and unknown. All these producers, in fact, finally cause fumes, reductions in the ovarian weight, follicles, and finally the fertility is disturbed. Air pollution and female fertility, systemic review of the literature, IVF populations and the general populations. In every year, IVF result is also reduced. In the general populations, the infertility rate has been increased. So the environmental occupational exposure to heavy metals, inhibition of Sertoli cells function, inhibition of steroidogenesis, oxidative stress induction, direct inhibition of the spermatogenesis finally produces the effect. So what we can do for this in future? Additional research targeting lifestyle factors, that is very, very important. And sperm test should be performed in the earlier stage itself. Occupations which are all hazardous has to be counseled to the patients that you are doing such a work that can be a complications in future. So these are all to be the counseling which can be done. And the conclusion is avoid smoking, avoid chemicals, avoid this hair spray, coloring dyes. These are also in fact reduces the
Kindly mute everyone.
reduces the fertility. And avoid using the chemicals and avoid the heat food and eat hot. And always you should counsel the men not to have the tight pants at all times. Excuse me, please unmute. So eat deep water first.
Dr. Aruna, please mute yourself.
In general, the substitute natural products for synthetic products and buy products at your local farmer's house. Avoid canned foods. Avoid stay in places where there are chemicals. Do not give young children soft plastic toys for children, even for 3 years. These are all the things has to be done. So the take-home message is promoting healthy behavior that can help maintain and preserve fertility. Promoting prevention, early detection, and treatment of medical conditions which can disturb the fertility. Reducing exposures to environmental, occupational, infectious, and iatrogenic agents that can reduce the fertility. So once again, I thank you. So this should be the clean environment should be there. And nowadays, this is also one of the causes for infertility. I thank Supriya and Priyanku for the opportunity. And Monica, thank you for the continuous follow-up. Bharti, all the best. Kalpana, all the best.
Thank you very much, madam, for your wonderful presentation on environmental factors affecting male and female fertility. You have given very good take-home messages, and you rightly said that environmental pollution really matters a lot. And take-home message was very good, like promoting prevention, early detection, and treatment of medical conditions that can threaten fertility. These were the tips you have told us. So, madam, very nicely summed up. You also said about the HPV vaccine. That is very much important in our life.
Yes.
Stress, madam, it is these days, I think everybody is having stress, right from the children, young children. So that also is a very important cause of infertility. So thank you very much, madam.
Subhash Malaya has joined my chairperson.
Okay. So he should give the concluding remarks now. Over to you, Subhash.
Good evening, madam. Good evening, madam.
சுபாஷ் நான் பேசுனது என்னன்னே தெரியாம நீ இப்ப கமெண்ட் கொடுக்க சொல்லு சொல்லு. ஏ சுபாஷ் tell
சுபாஷ்
something.
வாயை மூடிட்டாரு, சைலண்ட் ஆயிட்டாரு.
Yes, madam. Yes, madam.
Nothing. Thank you, Subhash.
Thank you, madam. Thanks a lot. Sorry, I joined a bit late, madam. I just finished the case about 10 minutes back, madam.
No problem. So Priya was there. No problem. Thank you.
Thank you, Dr.
Thank
Subhash,
you so
for
much,
joining. Thank you, madam. Thank you. We are over with this session. I hand over to Monica.
Thank you so much, ma'am, for chairing this session, and thank you, Subhash sir, for joining in. Thank you, Dr. Sampakumari ma'am, for accepting our invitation to be our faculty. I now would like to introduce the star moderators for the panel discussion, Dr. Alka Pandey madam and Dr. Bharati Rajshekhar ma'am. Dr. Alka Pandey madam is the Associate Professor of the Department of OBGY at Patna Medical College. She is also the Vice President FOGSI elect and a member of Governing Council member of ICOG in the last year. She has been the chairperson of Practical Obstetric Committee. We welcome you, ma'am. Dr. Bharati Rajshekhar ma'am is the coordinator for Public Awareness Committee in the South Zone. She is a medical director and OBGY consultant in Karnataka, as well as president-elect of Kasoga in the year 23-24. She has been the past honorary secretary in the last year, and she works at Sayadri Multi-Speciality Hospital, Hassan. She has many national and international lectures to her credit.
Yes, Monica, you can shout it. Thank you.
Yes, ma'am. Yes, ma'am. Thanks. I would now like to introduce our expert panelists. Dr. Rekha Rajendra Kumar, ma'am. She's a gynecologist and holds first rank in MD at the university examinations. She's a practicing gynecologist for the last 31 years and the president-elect at BCOG from the year 23 to 24. She's also the South Zone coordinator for the FOGSI Infertility Committee and the chairperson of Infertility and EIT Committee from Kasoga. She has been the chairperson of Ethics and Medical Legal Committee in the year 23 to 25. We welcome you, ma'am. I now would like to introduce our panelists, Dr. Sapna Sridhar, Dr. Selva Priya ma'am. Dr. Sapna Sridhar ma'am is a consultant at Thrissur at Mother Hospital, also at Chandramati Hospital, and she is the scientific committee chairperson of COGS. Dr. Selva Priya needs no introduction in the South Zone. She is the director of the Spring Fertility Fetal Care and Fetal Gene. She's also the clinical director of NDGH IVF Department of Reproductive Medicine. She is the vice president of Nagarkoil OBGY Society and the secretary of IFS South Tamil Nadu. She is the chairperson of Ethics and Medical Legal Committee of the Tamil Nadu Societies and the coordinator for FOGSI of South Zone, as also the social media convener for FOGSI. I welcome you, ma'am. Our next panelist, please. Dr. Archana Singh, ma'am. She is a professor of OBGY at GMC and is consultant at Yashoda Hospital, Hyderabad, and at Basant Sahani Hospital, Hyderabad. She is the secretary of OBGY Societies of Hyderabad in the year 2021. She is a brilliant academician. We welcome you, ma'am.
Thank you.
The next panelist, Dr. Rajashri Yalliwal, ma'am. She has 16 years of experience of OBGY. She is the associate professor of BM Patil Medical College. She also has presented various papers in national and state conferences and has 25 publications in various journals. She has a prize for presentations in Kasoga 2019-16 as well as at the UA FOGSI 2004. We welcome you, ma'am. Dr. Annapurna Yalla is a laparoscopic and robotic surgeon, the professor and in charge of the simulation course. She is also working at the GSL Medical College Rajamundry and a member of the endoscopy committee of the IFS South Zone. She has conducted numerous workshops and has been a faculty in the national and state conferences and has been the organizing secretary of APCOG 21, and she has 16 publications to her credit. We welcome you, ma'am. Dr. Mary Ain is the president of Nagarkoil OBGY Society in the year 2016 to 2018. She is also the current president of the Rotary Club She is also the chairperson of South Zone Women Doctors Wing and the Kids. Webinars. We welcome you, ma'am.
Monica, your network is poor, I think.
Ma'am, your voice is cracking.
Yeah, we're not hearing you.
Am I audible, ma'am?
Yes,
Now
ma'am.
you're
Now it is
audible.
audible.
Yeah, ma'am. I have been trying to call Alka, ma'am, but her number is out
Yeah,
of reach and she is not responding to WhatsApp calls also, ma'am.
I think she's
You
not
can
in
carry
station.
forward the panel.
Yeah, sure.
No?
Rekha is there. Rekha will be there to help me as an expert.
Yes, ma'am. Yes, ma'am.
So a very good evening to all of you. And I thank the Public Awareness Committee of FOGSI and the Adolescent Committee of FOGSI for giving us this opportunity. And I thank all my panelists for agreeing to be on this panel. And special thanks to Rekha to consented to be the expert. And I think she will help me be the co-moderator if the need comes.
Yeah.
So I will start sharing my screen and yeah, it's visible.
Yes, ma'am.
Yeah. So, well, infertility, as we all know, is defined by the failure to achieve a successful pregnancy after 12 months or more of appropriate, timed, unprotected intercourse or even a therapeutic donor insemination. Earlier, we were...
Sorry, ma'am, sorry to interrupt, but
Yes.
it is not full screen.
Yeah.
I think your this PowerPoint version is low.
I know, but here for me it is full. It's on.
Yes, ma'am. But
So what do I do now? Do I share it with you? I
yeah,
think I
ma'am.
have shared it on. I have shared it on the group. My PPT is on the group. If you can share it.
Yes, ma'am. Just let me check.
Any one of you, I've sent it on the group.
Ma'am, can you please send it once again, ma'am? Actually, it
Whom
is not
should I
showing
send?
in the group. That's why, ma'am. I will be share on your behalf.
Okay, just tell me your
Ma'am, you just share it in our webinar group.
infertility. Yeah, the infertility webinar group.
No. 08/06.
Ma'am, you can continue talking. I will share it with him right now.
Yeah, please do that. I think that's
Yes.
better. Yeah. So, as we have all know, there's the increased prevalence of infertility in the recent years, and part of it at least is attributed due to lifestyle factors such as obesity, smoking, and the high incidence of sexually transmitted infections. And of course, environmental pollution also contributes to the decreased fertility in the present generation. And in addition to that, there is a lot of interest in postponing the first pregnancy in the developed world.
Dr. Bharti, 1 minute. The slide move ಆಗ್ತಾ You're in the first slide only. Is that okay or
it's not moving?
No, we are seeing only the title slide.
Ma'am,
I think he will share.
Bharti, ma'am.
Sure. Yeah, I stopped sharing.
Just wanted to inform you.
Yeah, I stopped sharing.
Yes, ma'am. I am sharing on your behalf. Just in a second.
Yeah, I think that would be fine. So I need to update my PowerPoint. Is it that way?
Yes, ma'am. Yes, ma'am. It is an older version and it's having the it is not compatible with Zoom.
Okay, fine. I'll get that set right. So you will move the slides for me?
Yes, ma'am. Just tell me when to move it.
Sure. Yeah, you can skip this. Next.
Yes, Bharati.
Next. Yes, right. Next. Let's not waste time. So we all know what is primary infertility and secondary infertility. I'm not going to go into the basics. Next slide. Next slide. Well, anyway, we know that male and female infertility contribute almost equally to the incidence etiology of infertility, and another 1/3 are due to unexplained causes. So it is necessary that we as clinicians provide hope to these distressed couples. Next slide. Next slide. So what do we need to do? No, just wait there, please. Yeah, so you need to determine the etiology of infertility as expediently as possible, provide the couple with recommended treatment protocols, educate the couple about their specific disorder and available alternatives, and determine expected success rates and approximate costs for recommended therapy and do the counseling for them. Next. Just skip this. This was it was the unedited version. Yeah. Coming to case number 1, because it's a case-based approach, we have a 28-year-old nulli gravida homemaker studied up to the 5th standard. Her husband is a 30-year-old carpenter. They're married for 3 years and they have not conceived, and they have come for advice to the clinician. Next slide. Yeah. So how do we proceed in this, Dr. Selvapriya? Is Dr. Selvapriya there?
Ma'am, she is not.
Anybody
there.
can take, anyone,
Yeah.
anyone can take. Dr. Aruna Kamath or Dr. Rajeshri.
Sapna ma'am is there.
Yeah, Sapna can take the case.
Yeah. Good evening, everyone. First of all, thank you for this opportunity to be with such a group. And regarding this couple, we have to evaluate them as a unit. It's not either the female alone or the male alone, because both combine together. So we have to go in a systematic way. First with the history, then the examination, and then only the investigation part. So the history should be detailed one with regards to
Next
male
slide.
partner.
Next slide.
Shall I go with the
Yeah.
history?
Yeah, please go with the history. What salient features will you ask in the history?
Yeah, regardless of the years of marriage, we need to ask how long they have been together. I mean, most of the time they might not be together, or they might not be knowing regarding the period when to try and the frequency of intercourse. That is, a coital history should be taken. Frequency of intercourse. Yeah, are there any problems that is encountered by the female or the male, or any of that kind? Then coming to the menstrual history, we need to ask regarding the cycle, the frequency, the regularity. Is she having any intermenstrual bleeding or any postcoital bleeding, to rule out various pathologies? And if it's a case of us, now in this case, she has not become pregnant yet. If it was a second gravida, or I mean, with the previous obstetric history has to be sought into, like whether there was any history of infertility, treatment required in the previous history, previous marriage, previous pregnancy. And regarding the contraceptive use, whether they have been following any contraceptive practices, any history of sexually transmitted infections, or any other kind of difficulties encountered, or whether they are on any other medications, either the male partner or the female partner. And that is with regard to coming to the medical history. We also
Next
need
slide. Next slide.
various endocrinopathies, and including the thyroid disorders, or any diabetes, any tuberculosis, any prolactinomas, any of that kind. And also any history of any infections, or like chemotherapy or radiotherapy in the past, which might be a contributing factor. And regarding the history of surgical history, coming to the surgical history, any history of surgeries in the past, both with regard to the male partner as well as the female partner. Especially in case of males, we'll have to go for history of any hernia, any undescended testis, any of that kind, or history of mumps for the male partner. Then coming to the family history, any history of infertility in the family.
Next slide. Next slide, please.
Any other genetic conditions which can be transferred to the offspring, or any other history in the family. Then coming to the occupation. Again, regards to any toxic, the exposure to any toxic agents which might contribute to the fertility. And also the personal habits like smoking, alcoholism, or
Next slide. You can keep moving the slides. Yeah, just please go ahead.
So we'll have to go in a systematic way with regards to.
Next. Yeah, so Sapna, as you rightly enumerated, I think a very detailed history of the male and the female partner is very, very essential. Next slide, please. So would any of the other panelists or our expert like to contribute to anything else in this? Next.
History-wise, everything has been explicitly explained. I don't think
Next
anything
slide.
is remaining
Yes.
in history.
So next slide. I think where we fail is the male in taking the elaborate male sexual history. I think as clinicians, we sometimes do fail. So either if we are, I would say that if we are not able to do it, at least we should send them to male as a gynecologist who specializes in male infertility, because sometimes very cursory examination is done by the gynecologist when it comes to the part of the male history taking. I think that's what generally happens. We examine the female, but we give very little time for the male partner there.
Yeah, and about the ejaculation disorder or even the examination part, it will not be possible for us also.
Yeah, so
Many
that
times
I
it
think
is
we
not
should keep in
common.
mind.
And sometimes they are taking steroids. So all either Ayurvedic drug, natural drug, or weight management, all those drug addiction also we have to ask for male history.
Yeah.
Yes. Next. Yeah, so taking the elaborate history in this particular case, there were no coital difficulties, there was no history of contraception, and no prior evaluation was done, and there was no past history of any surgeries or any pre-existing disorders like diabetes or hypothyroidism or hypertension. Next slide. So, Dr. Archana, what are the salient aspects of the physical examination that would you like to go across?
We have to examine both male and female. So first we'll start with weight and body mass index, then going through blood pressure and pulse. Then of course we have to see thyroid enlargement and breast examination for the female, and signs of androgen excess is there. And Tanner staging of the breast has to be done, and we have to see if signs of hirsutism, anywhere excess hair is there. Then comes the vaginal and cervical abnormalities, and if any screening has been done or not, or any intervention has been done. Pelvic and abdominal tenderness, any organomegaly is there. Then comes uterine size, shape, position, mobility, adnexal masses, and definitely we have to see any tenderness is there in the fornical tenderness particularly. Then we have to also
Change the
examine.
slide, please. Sorry. Yeah.
We have to also examine the male partner also for how the genitalia is there. The penis, hypospadias is there, testes volume. Then we have to rule out varicocele and spermatocele, and any palpable thickening if we are finding. Definitely we need that their examination is needed by a expert. Then the pattern of clothing, lymphadenopathy and pattern, and any male with gynecomastia also needs hormonal evaluation. And
can we change the slides, please? Yes. So this is the ASRM guidelines. We say that we have to, following the physical history, we have to have a very detailed physical examination of the male and the female. Next slide, please. Yes. Anything else? This is the what we need to examine for the male. Would any other panelists like to contribute? Next slide. Yeah. So now I would like to ask Dr. Rajeshri Aliwal, what are the lab tests that you would do for this couple? Is she there? Dr. Rajeshri, if not, Dr. Annapurna can take the.
Yes, ma'am, I'm here.
Yes.
Good evening, one and all, and thank you for having me, the panelists and the experts. Thank you for contributing with me. So I'm basically not an infertility specialist, so I get a lot of these couples before I screen them and send them to the specialist. So initially when the couple comes to me, as madams have before me have elucidated very, I take a comprehensive examination and I do a physical examination. And after taking a history and examination, basic labs which I would like to send for the female would be a baseline ultrasound. If she comes on day 2,
next slide.
Day 2 or after menstruation, if they come, a baseline ultrasound to check for the uterus, the morphology of the uterus, endometrium, adnexal pathology, and the general uterus and vagina. Then afterwards, after general exam, after the ultrasound, then antral follicular count also I would like to do at that baseline.
Next slide, please.
Then basic hormonal assays would be thyroid stimulating hormone And if she has any galacturia, I would like to do a prolactin. And basic examination like a complete blood picture. These are the basic investigations I would like to do for the female. And for the male partner, I would like to do a semen analysis in the first sitting.
Prolactin actually is necessary for even if there is no galacturia, because galacturia is a little bit advanced stage and anovulation may be subtle with marginal elevation of prolactin. So I feel future slides probably may say that prolactin is one of the special tests, but most of us do include it as a preliminary test like TSH.
Yeah, like thyroid. We generally do it, though it is not in the guidelines. We do thyroid and prolactin together.
Correct.
Yes,
because there is subtle hyperprolactinemia sometimes, which may be a contributory factor for anovulation. So basically, it is that for the female partner, we have to do the ovulatory studies to find out her ovulatory reserve, and the other one is the transvaginal ultrasound, which we will do to find out any abnormalities in the endometrium, uterus, as well as the anything like polycystic ovaries or what. And the male partner, I think the first thing we would do is a semen analysis along with the general lab profile like his thyroid, his lipid profile, his blood sugars, and any serology for infections. I think those would be the basic tests that we do. Next slide. Next slide. So I think Dr. Annapurna did speak about the ovarian reserve, that is the AMH, antral follicular count, FSH. These are the basic tests I think we do for all women who come to us. So is there anything else the panelists would like to say about these three tests that we particularly need to keep in mind?
Madam, do we need to do an AMH at the first initial baseline investigation for all couple? For example, this couple is, she's just 27-year-old, married only for 3 years. What is your opinion about that?
Can I answer that question?
Yes, Rekha, please.
Yeah, see, there are two ways of talking about it. Like when they come to us, the infertility specialist, it is one step ahead than coming to a general gynecologist. If you say she's 27, in spite of that, many of the time we do see that patients do come with a very low ovarian reserve, where it is very necessary for you to either treat at your level or send it to a next level. Suppose her AMH, because there is no other clinical manifestation of having low AMH. Suppose you are holding on to her with the low AMH, not being tested, you may be wrong in your place, detaining her for a longer time. Of course, you may say that antral follicle count is one of the important things to make out, but many of the times one is complementary to another. So I can say that AMH will help if it is more reflective of a polycystic ovarian syndrome, and AFC is more reflective of a poor ovarian reserve. So you will get idea doing both the tests, and it is one is complementary to another, and we prefer doing both the tests together. Advantage of doing AMH is like you can do it on any day of the cycle. Like you don't have to do it on day 2 or something. It's always better. You will know where you stand. Like, should you send her to somebody else or should you keep her with yourself? Though 27, that does not translate all the time that good fertility at 27.
Yeah, like for example, if the AMH is low and we have not done it and we're just putting them on letrozole and giving her 3 cycles, 4 cycles, we are worsening the situation by the time we send them to the infertility specialist, I would say. So I generally, though I'm not in the tertiary level infertility setup, I generally do both together.
Okay, ma'am.
Next slide. Yeah, next slide. Next slide. So basically, these are the things we do. The previous one, please. The previous one. Yeah, we do the fertility hormones like the FSH, LH, and then the ovaries, antral follicle count. And then what is the place of the tubal patency test? I would like Dr. Aruna Kamath to take this question. Tubal patency test. When would you advise and what would be your choice?
Yeah, normally, madam, if they have a history, like they have severe dysmenorrhea, any history of any discharges or something like that, where we suspect a block, I would do it immediately. But normally what I try to do is, after all the other tests, try to stimulate with the letrozole and get ovulation. Suppose even after with this, it's not happening, then I go for that. Because I've generally seen if we do HSG in the beginning itself, they really get scared. Such a painful test in the beginning itself, and then they'll just stop everything altogether. So that is what I normally follow, but I tell them, so this is one of the factors. I show them with the diagram that this is possible. And then, yeah, HSG has to be done.
Any input from other panelists on this?
Madam,
I am also for it, ma'am.
Ah,
I would also prefer to do a hysterosalpingogram after explaining the risks and the entire thing about hysterosalpingogram. And because I feel 50% of the infertility cases are related to the tubal block. So first we'll rule out the structural thing and then only it is better to proceed further. So I advise at least they do it, if not the first cycle, at least the second or third cycle. If they do, I prefer it more, ma'am.
Probably, I would like to pitch in. Probably, I feel the scenario is little bit different. Like the investigations, what a fertility, the tertiary center, what we do is little bit probably different compared to the other kind of like the regular obstetrician gynecologist does. And I feel both the ways it is right. Like when they come to us, they would have gone through all these steps. So definitely we will be checking the hysterosalpingography, or sometimes even they come with the block and they come directly for IVF. That is one way of looking at it. But again, as you say, about 30 to 40% of female infertility is because of anovulation, and those kind of cases, like it's a clear-cut case of PCOS, never conceived before, tubes have never got meddled in any way, like PID or any kind of way, tubes were not meddled, ultrasound looks quite healthy. Probably you can put them on letrozole, make her try to conceive, and if she does not, then go for HSG at the primary level. But I feel HSG, if you give atropine, make her understand it's not that painful a situation, because you have to do a very slow HSG. It is not a painful procedure most of the times.
Yeah, thank you, Rekha. Yes. So I would, as you said, give them 1 or 2 cycles if they have no incidental findings or pointing to tubal factor, and then counsel them about the procedure, and they do take it up quite well. Next slide, please. Next slide. So what are the indications? Like generally we say that, okay, we wait for some time and then let's do, but there are some indications we have to do immediate evaluation whenever there are cases like we suspect endometriosis, tubal or peritoneal disease, oligomenorrhea or amenorrhea. Going to the next slide.
Even
next
the age,
slide,
madam,
please.
if I can add, even the
Yeah,
age
I'm coming to
woman.
that. Madam, I'm coming to that next. That's there in the next case. So we're just coming to that
in
next.
the previous slide, even if the combination of other factors like endometriosis of grade 1 and 2 plus additional other factors also is an indication. It
Immediate, yeah, immediate follow-up is required.
Yes,
next, next slide, please. Yeah. So, what are the tests which you would not do at the first setting, Dr. Sapna or Annapurna? Any of you could take the case. What would you not do at the first setting?
Though I am an endoscopist, madam, I would not like to do a laparoscopy at the first setting, or any advanced testing like a postcoital test or antibodies for chlamydia, thrombophilia testing, or genetic analysis, karyotyping. These are the things which we wait for a long time, and we would refer to an infertility specialist before doing these kind of tests.
Yeah, rightly, Sapna.
Dr. Annapurna, what is your take on hysteroscopy?
Madam, rather than hysteroscopy, I would prefer SIS, madam.
Okay, fine. You're right.
Thank you.
Well, hysteroscopy also, I think, Rekha, we will not do it at the first sitting.
That's what I'm saying.
Yes, a transvaginal ultrasound shows us something significant like a polyp or a submucous fibroid. I think we wouldn't advise a hysteroscopy at the first sitting.
I'm also telling the same thing, and HSG gives us a lot of information.
Exactly. So I generally go for the HSG on the 2nd or the 3rd month.
Yeah, exactly.
Madam, what is your take on SIS, madam? SIS is...
Well, SIS, there are sometimes...
So way to know the...
Rekha, you want to take this question?
There are many people with the different schools of thought. Some people are very exclusively happy about the SIS part, and some people with HSG. I go for HSG, not so happy with SIS. Of course, both have their pros and cons. I totally agree, but I am happy with HSG.
Yes, I was doing SIS a few years ago, but then I later on switched to HSG because I felt the results were much better, and the interpretation and the picture, the exact picture, we get a better picture in HSG rather than in the SIS.
You have the films in front of you. You can reassess, go through that again. So many things.
Madam, what about the pain, madam, when you have seen? Because my infertility center specialist does an SIS, and I send HSG, and the patients are very, very pain. They tell a lot of pain with HSG, but they accept SIS somehow.
And before you send them, you can just put an diclofenac suppository if you want. But generally, our patients have never complained. Only post-procedure, they're given an analgesic and they take rest for about 10 minutes and they go home. Otherwise, you can always give them, if they're so apprehensive, one atropine and one suppository of diclofenac does help.
And you do the HSG slowly, like
yes, slowly.
With the occasional advice, vocal
anesthesia.
Yes, with the vocal anesthesia, you do push the dye very, very slowly. It will help you for the procedure also, like the gradual filling. You will see the uterine cavity, the tubes filling and all that. And patient, it's a sudden uterine distension that causes pain. That too, if you haven't explained them properly. Otherwise, HSG is a very fast procedure. Maximum by 10 minutes you finish and no pain. I do regularly.
How many films you shoot, madam? How many films you shoot?
Only 2 films. Only
two films.
Yes.
Normally 2. Next.
Thank you.
Next, please. Next, yes. So let's go to the next. No, this is
so
just.
Could I just say something about the HSG?
Yes, Dr. Rajeshri. Yes, Dr. Rajeshri, please.
Thank you so much for inviting me, madam. In your experience, have you seen that some women conceive after HSG? Because I see
very many.
Yeah,
very many
I
we
do
have
see
seen.
a lot of that.
Yes.
So I do, though it's not really mentioned in the books that it's a therapeutic thing, but I do see that happening.
It does help, madam. It does help.
It has its own advantages.
Small mucus plugs. Small mucus plugs may just be dislodged.
Yes.
Yes.
And
Next.
it causes some immunological reaction, like what you do, a mini kind of endometrial scratch kind of a thing also happens in the endometrium.
And the cervical dilatation, maybe a little cervical dilatation, some stenotic lesion there. So, well, this case, the history was all, nothing was positive. I mean, she had a very good history. Physical examination, both were normal. The hormonal assay, TSH was normal, AMH was also normal. TVS scan, she had no abnormalities. The tubes were patent on HSG and the semen analysis was normal. So, how would you go about managing this case, Dr. Rajeshri? Next.
Yes, so since everything is normal and she looks like not such a high risk patient, I would straightway go for ovulation induction for her few cycles and then we'll see what happens.
Next slide. Any other opinion from the other panelists?
No, I think that's it.
Yes.
Yeah, that's the way to be done.
I concur, madam. We plan for an ovulation induction and time coitus and explain to them in detail how the fallacies and the the misconceptions of having the intercourse and all that. And I think we can follow them with an ovulation study if possible.
Yeah, I think let's go to the next case. Next. So this is case number 2, 37-year-old Nali Gravida. She's an engineer with regular menstrual cycles. Husband is also an engineer who's 39-year-old. They're married for 8 months, no coital difficulties. There's no history of diabetes, hypertension. There's no history of hypothyroidism or prior surgeries. Physical examination, as a detailed examination as enumerated by Dr. Sapna, we have examined. There's no significant abnormality detected. Next slide. Next slide. So when do we start evaluation, Dr. Archana?
Because both husband and wife, husband is 39 but wife is 37, and if they are above 35 and above, it is always better that 6 months we should take cutoff rather than what we take cutoff.
Sorry.
Rather than what we take as less than 35, we go for 12 months. But here, because she is already 37, we should go for 6 months itself is over. So we should go for evaluation immediately, rather than waiting for more time. And baseline investigations we can start. And because married life is 8 months only, so we have to rule out all the possible problems. If there is any endometriosis, dysmenorrhea, menstrual history, all detail we have to go, and then baseline test immediately we should start.
Yes, thank you. So that's the age limit. Less than 35 years, you can wait up to 12 months of unprotected coitus. But if they're above 35, you need to expedite the management, and even the protocols have to be expedited depending on the age, because ovarian reserve is going to decrease as age progresses. Next slide. So that is, I think, the earlier we need to refer them to the ART specialists instead of rather beating around the bush and keeping them with us. So older than 35 years should receive an expedited evaluation and undergo treatment after 6 months of tried unprotected coitus. Next slide. Next slide. Next. This PPT is unedited, that's why. So, well, Dr. Marianne, what would you talk about the counseling? Because very often, I think this is where we clinicians, of course, in ART centers, they have their own counselors there to do the counseling. But as a general gynecologist, the counseling plays a very important role. So how would you contribute to go about the counseling for this couple?
Good evening, ma'am, and good evening to everybody. What I would prefer is like I will make the couple sit before me, and then I talk to them about what the causes of infertility, and regarding their own investigations, what has to be done, and if it is already done, what are the negatives and what are the positives regarding the test, and the success rate also, like what are the possibilities, earlier possibilities, late possibilities, and how much they have to wait for it, and how patiently they have to come for the fixed appointments. All this I explain to them personally and make them convinced that they are not dejected totally, like I give them more of positive support, saying that they will get it, and how the treatment should be and how they should follow the treatment exactly. All this I tell them orally, and if needed, I call the parents of the couple also and I speak to them. And yes, ma'am, that is also there. And what happens is, infertility patients, if they come to us for the first time, it's okay. If they had gone to different doctors and come to us almost vexed, and each doctor would have though they give the same kind of treatment, sometimes patients also take it in different ways. So the pros and cons of every possibility of the treatment should be explained to them. And afterwards, once they are convinced and when they are given enough, I always tell them, first believe in God, then believe in yourself, third believe in ourselves, because that faith is very important here. And I tell them first orally only, and certain things before we do the investigations, after we get the reports, I make a return information to them personally, ma'am. So this is how I do it. And such kind of patients, they require a lot of psychosocial support. So that is very salient and we need to give them. And the possibilities of treatment in a particular center also, I keep telling them, because I have my nursing home in a village level, so I can't do all that fertility specialist does. So I tell them what is possible in my hospital, and the fertility centers where I refer also, I give them options, because we know them better, but they may not know them. So they will have their own thoughts about the different fertility specialists. So that also I do. And then when I am referring to the fertility specialist also, I make I talk to the persons personally, and I always keep that we are well coordinated, all three of us. So this is how I do, ma'am.
Yeah, that's exactly what we need to do. We need to explain to them the scientific basis of what we are doing, explain to them what are the results and what we are going to do, why we are giving them ovulation induction, why we are doing IUI, what are the results. Is very, very important, so that we avoid these couples flitting from one clinic to other without any results, because unless they are consistent with one practitioner, it is difficult to get results within 1 or 2 visits. It's very, very important part of our armamentarium. Next slide. Yes, so we have case number 3 now. She's a 27-year-old nulli gravida homemaker with regular menstrual cycles. Husband is 29 years. He's a driver. An examination of the female partner, everything physically and her history appears normal. Next slide. Next slide, please. Yeah. So how do you evaluate the male partner now? Anybody? Dr. Rajeshri, Dr. Archana, you can take this question. Dr. Rajeshri?
Yes, so the male partner, when we're examining, so the best thing is if he has come along, it's very good. So general physical examination of the general appearance of the male partner itself can give some clues away. And next is you will examine the person. If he is ready, willing to be examined by a gynecologist, well and good. Otherwise, better to send them to a urologist or with whom they are comfortable. So on the examination, height, weight, body mass index, and overall, whether you are thinking that he is having any known syndromes like time filters can be masked. Genital examination, volume of the testis, any signs of varicocele or any thickening of the epididymis should be noted. And if they want to see the prostate, okay, you can go for the rectal examination. But more so, I do in my practice, what I do and very fond of is sending for the scrotal ultrasounds, where it gives a lot of information.
Next slide, please. Yeah, so we have to do the general examination first, and the next, how would you evaluate? You've done his physical examination. Dr. Sapna, next slide, please. Next slide. So on examination, this fellow complains of erectile difficulty. He has a swelling in the genital area since a year. It is not painful. He is a cigarette smoker, about 5 to 6 cigarettes. He has a lot of tea as he's a driver. No prior surgeries in the couple. His BMI is 28. And on physical examination, it was diagnosed that he has a grade 2 varicocele. Next slide. So next slide. This history is over. We have finished this. Sorry, this is an unedited version of my PPT which I posted. Next slide, please. Next. Yes. So basically, before we even go for the the scrotal ultrasound, we have to do the semen analysis. So Dr. Sapna, what are the guidelines for the seminal fluid analysis for this male?
Yeah, there are strict guidelines, and semen analysis should be done only after following those strict guidelines. And the abstinence should be explained, and it should be done in the specialized laboratory by trained personnel. So
yeah, so we have to follow this protocol of the WHO standards of doing a semen. Next slide.
And,
yes, Sapna, you can go ahead.
Yeah, this is the latest WHO reference limits, which the process volume should be at least 1.5 ml, and total the sperm concentration should be at least 15 million per ml, with total motility of 40% and progressive motility of 32%, and morphology 4% it should be normal, and vitality should be.
Next slide. Yeah, thank you. Next slide. So this is how we give the nomenclature. All of you are familiar with this. Next slide. Next slide. Yeah. So what the ASRM guideline says is, yeah, Sapna, you can go ahead. You need not do this anti-sperm antibodies.
To confirm it, we have to repeat the semen test once again after 3 months.
Yes.
However, if it is grossly abnormal, we can repeat it as soon as possible. And the other tests like anti-sperm antibodies and all the other tests are not done routinely. So it is, and also before doing the semen analysis, we should rule out that he doesn't have any infection past few weeks, and like viral, he's not on any antibiotics. So all these also have to be kept in mind.
Yeah, even his lifestyle, like his smoking and all that, I think he'll have to cut down before we repeat a semen analysis if it is abnormal. Next slide. Next slide, please. So when and why are the second line investigations indicated? Dr. Archana or Dr. Annapurna?
The second line test will be indicated only if the semen analysis is abnormal, and we have to do before going for scrotal testing and all, or testicular biopsy, we should always do the blood test investigations. Either it is hypothyroidism or they are having high blood sugar. So all these things, once we have ruled out, then only we have to go for second line of investigation, and then we have to see that how is the scan finding of scrotal finding, because it should be done in a proper place by the expert, and which we have to see the testes volume, the ultrasound pattern and morphology.
Next slide.
And how the hydrocele is, if there is any hydrocele, how is the vascularization, and we have to rule out any obstruction is there or not. So these things, if they are there, we are always sending them to a specialist, so that immediate treatment is taken care rather than the delay is there because of the male factor. So first semen analysis, blood test, and then only we have to go for scrotal examination.
Only if the semen analysis has any abnormality, or physically you feel that the testis volume is reduced, or there's a hydrocele, or there is a varicocele, I think then we advise for scrotal ultrasonography. And in that they need to do a detailed study of the volume, the size, any calcification, signs of inflammation, any epididymal cysts, that all this detailed scrotal sonography is required. Next slide. And of course, if we suspect infections, we will also look for, ask them for a transrectal ultrasound in this man. Next slide. Next slide. Yeah, next. Next slide. Next. So, are routine hormonal assays required in male infertility, Dr. Annapurna? Dr.
I don't
Aruna?
think so, madam. Yes, ma'am, I'm here. I don't
Yes.
think so. Routine hormonal assays are required if the semen fluid
Next slide.
analysis is normal. If the semen fluid analysis is abnormal, then we would like to send a FSH. If he has any problems of abnormalities like oligozoospermia or oats, or if he has any erectile dysfunction, or the testis volume, if we have done the scan, is less, or in clinical examination also, if the volume is less, then we would like to send for hormonal assays.
So we do this FSH and testosterone only if these following conditions we do find in the examination or the clinic laboratory tests. Next slide. Next slide. Next slide. Sorry, let's move because I think we have just another. How much time do we have, Monica? Next slide, please. Next slide. So what is the role of genetic testing and testicular cytology or histology?
Ma'am, we have another 15 minutes till 6:45.
Yeah, we'll finish.
Yes.
I'll finish by that
Yes,
time. Yeah. Anybody?
Yes.
Next slide. Dr.
Genetic
Rekha.
testing. Yeah, like certain times it is very much necessary. Say example, you find the testicular volume very small. Clinically, he appears like a Klinefelter syndrome kind. Like we know that broad chest and
next slide, please.
Low hair and all that kind. Or even sometimes it's a obstruction, like everything looks normal, that it looks like the normal testis volume and the size, but you feel there is an obstruction, like the congenital absence of vas. So these are the conditions where we really think that, or azoospermia cases. So as you put the list, certain times we definitely need the investigation when it is indicated.
Yeah, thank you, Rekha. Next slide. Well, next slide. Next slide. So this is when we look for such things. So well, in this particular case, we said he has a grade 2 varicocele. His semen analysis did show some teratozoospermia. So how would you manage? Dr. Marianne? What is the management of varicocele?
Regarding the management, I refer him to a neurologist and the surgeon regarding the grade 2 varicocele. And after getting their opinion and as suggested by them, the patient will be taking medicines for the grade 2 varicocele. And other things like, we have our own drugs of choice. So I make them take those drugs also. I advise them to modify their lifestyle. Like I ask them to stop smoking and drinking and their regular habits, because it all depends upon their nature of work. So this is what I tell them, and mostly I do it according to whatever the urologist says. So regarding the male infertility, I usually ask them to consult and follow their own treatment.
Madam, if I can add,
yes, please,
grade
Anna.
2 varicocele. Yes,
yes.
grade 2 varicocele needs surgery, madam.
Next slide, yes.
Provided because we find the cause of the, probably it might be the cause of the oats, so it will need a varicocele or occlusion by clips or varicocele repair. It could be done laparoscopically or open surgery. Any decent surgeon would do, and probably after 3 months, the oats might disappear.
Yeah, the guidelines do say
they always require surgery for grade 2 varicocele.
Only grade 2, madam. The guidelines say that it should be considered when we have a varicocele with abnormal sperm parameters. When he has abnormal sperm parameters, you do it. Otherwise, they should not recommend varicocelectomy for non-palpable varicocele just because it is found on scanning.
That is what I forgot to. Okay.
Yeah. That means usually in early stages of varicocele, we do not need the surgery if the semen is normal. If the semen is normal.
So basically, semen's parameters should be abnormal, and varicocele then is when we decide on surgery. And if the semen parameters are normal, it is not necessary. But studies do show that repair of varicocelectomy does increase the sperm parameters if they have abnormal sperm parameters. Next slide. So this is what we wanted to put across in this case. So basically, it's physical examination, semen analysis, and hormonal analysis and scan for the men. Next slide. Next. Yeah, so this is case number 4. She's 35-year-old. She had a previous ectopic for which her left salpingectomy was done. Her cycles are regular. She has just white discharge. Husband is 37 years, engineer. They're married for 5 years. No coital difficulties, no significant pre-existing diseases like diabetes, hypothyroidism. On examination of the lady, she has got cervicitis per vaginal examination. Uterus is normal. Next slide. Next slide. So what is the place of ultrasound?
Can I take this, madam?
Yes, please, Anna.
Yes, she has a erosion. She has a previous history of ectopic. So I would think the thing, if I have the record of her previous surgery, then I would like to see if the other tube is normal or not. And clinical features, because she has erosion, I would like to take a pap smear and swabs for infection. And I would put her in the high risk category for PID, especially chlamydia PID, because we wouldn't know it in routine tests and treat her accordingly. Ultrasound definitely has a role, madam. We can see how is the other, if the tube is dilated, then it would be visible, and probably the ovarian, the tubo-ovarian, if she has any chronic illnesses, she might have any tubo-ovarian mass and all. So ultrasound has a role, but I would like to put her in
on
the
ultrasound. We saw that this lady has a right hydrosalpinx. The uterus and the tubes are normal. So what is the plan of management for this?
In ultrasound, it is of course about the tube. What you have told is correct, Dr. Annapurna. But you will also check for your routine things. What you have
uterus and ovaries.
Yes,
uterus details also.
Of course,
you will
yes.
check. That is
uterus, ovaries. Yes.
Or, yes. Okay.
Uterus, the endometrium, and the pouch of Douglas, and the ovaries. Well, on ultrasound, this lady has an hydrosalpinx. She doesn't have a left tube. She's 39 years,
35-year-old, yes.
35-year-old, married for 5 years. So, Dr. Aruna, what would be the plan of management for this lady?
This, I think I would go for IVF only, madam, directly. Because one tube is not
Madam,
there.
I disagree.
Any other inputs from other panelists?
I disagree, madam.
I also disagree, ma'am.
Before going to IVF, I would like to do a histolaparoscopy and see the status of the tube. If the tube is really damaged, I would like to disconnect before referring her to a...
That is there, of course.
Yes.
Yeah.
Yes, I will
I also do the
same.
same.
Annapurna, can you explain why? What is the effect of hydrosalpinx on fertility? Next.
Madam, number one, she could have PID and any infection could be there. And many studies have said that hydrosalpinx and the fluid in the hydrosalpinx might be embryotoxic.
Yes.
Not only that, it could lead to recurrent ectopics as well.
So basically, the hydrosalpinx has a very poor outcome. So there could be endometrial damage, impaired ovarian function could be the cytotoxic effect of the fluid in the endometrial in the hydrosalpinx, and there could be, as you said, embryotoxic material may be there. Rekha, would you like to add?
Yeah, definitely. Before clipping the tube or hydrosalpingectomy, definitely some evaluation of the tube is very much necessary. However you want to do, either by DHL or by HSG. I definitely prefer DHL because she already has some problem there. Let me look at the pouch of Douglas. Let me look at the tube, the mobility, etc., and those things, and then proceed. And it is a one-stop solution. And hydrosalpinx, other than the ill effects what you have mentioned, it is also known to give on and off fluid leaking into the endometrial cavity, which is all the more when you're about to transfer the embryo. Endometrium would have come very nice during our frozen embryo transfer with the HRT cycle, but when you're about to transfer the embryo after giving a full dose of progesterone, that day you see some fluid there. So that becomes very difficult for us. That's one. The second thing, of course, if it is a recurrent fluid, we have to rule out tuberculosis other than PI.
Madam, if I can add, we can look into the inside of the uterus, do a hysteroscopy as well.
Yeah, we are doing there. It's always a hystolaparoscopy. It's always a hystolaparoscopy, I would say. Never just a laparoscopy.
Diagnostic histolaparoscopy.
That's why it's DHL. Histolaparoscopy. It should not be diagnostic. It should be histolaparoscopy and therapeutic.
And proceed.
Yeah.
Madam, I would request a question to Rekha, madam.
Yes.
Madam, if in cases of ectopic, when we see in our day-to-day practice, they come with infertility and the other tube is normal. However, we are not getting very good results when we go for just ovulation induction. So in your practice, would you still advise ovulation induction if the tube is normal, or you would suggest straightway to go for IVF?
No, I don't suggest
No,
for
I
IVF,
will
provided
wait.
one tube is normal, it is
Yes,
enough
sir.
for her to get pregnant. It is theoretically, they say that the same side of ovulation will give better result having the one healthy tube. We will never advocate directly for IVF, but make sure that the tube is healthy. Salpingoscopy, of course, nobody does, but you will get with the investigation what you do, you get a rough idea about the health of the tube. And if you're happy with the health of the tube, as Dr. Annapurna said, with scan, most of the time the tube is not visible. That itself says the tube is normal on sonography. So if you're
Yes,
happy with HSG and your ultrasound, please allow her to go for pregnancy. But I don't make them to sit at home and try to get pregnant. Invariably, they would have some age bar or tried enough, gone to many places, etc. So I tell them to take at least for the IUI, push them to the IUI treatment with ovulation induction concurrently.
Yeah, that's what we do. Ovulation induction and IUI will definitely improve their fertility prospects, I think, rather than just timed intercourse.
Madam, can I ask a question? Would you prefer delinking the tube or doing a salpingostomy at this point of time?
No salpingostomy.
What about the fluid and increase in the size of hydrosalpinx and the future problems that she might pose?
You could also do a salpingectomy after taking proper consent.
Yes, ma'am.
If you feel
But
that
doing
there's a lot of fluid and
salpingectomy,
obstruction.
does it not reduce the blood supply to the ovary theoretically?
No, you have to be careful about that.
Dr. Annapurna, I would like to add certain things here. Definitely, there is no scope for salpingostomy. It is the bet is between either salpingectomy or clipping of the tube.
Yes,
both have their own advantage and disadvantage. If you are doing salpingectomy, do it very close to the tubal diameter. And that to be the bipolar, not use monopolar, so that the lateral spread is very minimum. So that is quite okay. The results are almost similar to clipping. I do clipping if the tubes are very much not possible to do, very difficult to find, not, a lot of additions, those kind of things, I do clipping. Otherwise, I directly go for salpingectomy. Of course, before salpingectomy, make sure that AMH is normal. You have done enough counseling, especially telling them that you are a candidate for IVF post salpingectomy, because other tube would have gone. So make sure that your counseling is very perfect, so the medical legally you are very safe.
And consent, take proper consent and make them in their own language. Please see that the consent is written by them in their own language.
They think,
Madam, I think anyways we are doing delinking, doing the what you call salpingectomy would be preferable for her future life also. What is your opinion on that?
Yeah, maybe, because later on pyosalpinx, additions, pain, that also could be a possibility.
Yeah, serous tubular carcinoma.
But as Dr. Rekha said, it depends on how there are a lot of additions there. The ovary is adherent. You don't want to meddle with the ovaries. In such cases, you would rather delink than meddle with the ovaries and reduce her reserve.
And they think something like ovarian cyst, my cyst is gone, so now I can get pregnant. No, it is not like that. Your investigation and the treatment, especially the treatment, is stepped up. This is exactly what we have to tell them.
Yeah. Of course. Thank you. Next, this is the last case, just 5 minutes. Next, please. Next. So this is the one. She's a 28-year-old BA graduate. She's had irregular cycles from the age of penarchy. She's married to a 30-year-old businessman, married for 2 years, no coital difficulties, no evaluation for infertility, no history, no significant history. On examination, her BMI is 30. She has acanthosis, hirsutism. Her pelvic examination is normal. So what would be the diagnosis, Dr. Maria? Next.
It's a case of polycystic ovary.
Next.
Polycystic ovary, ma'am.
Yes, so we know it's polycystic. Next, what is the plan of management, Dr. Sapna? Next.
Since she is married only for 2 years and 28 years, I think lifestyle modification would be the first management that I would offer her, maybe for 3 months or so. And then afterwards, we'll have to evaluate her, of course. to rule out any other reasons of any androgen excess as well, and rule out any uterine pathology and rule out the thyroid function and prolactin, which we routinely do practically, though the guidelines say only if it's galactorrhea. But madam, can I just ask a question? Like, is it routine to do FSH and LH? Is it really required?
Next slide. I have that. I think I have that there. No, sorry, it's not there. Yeah. Well, routinely it's not required, but I think LH we do when if you are going for ovulation induction for this girl after all the evaluation, lifestyle management, and she hasn't conceived, and then we are going to do ovulation induction for her. I think at that time we would like to have her LH and FSH levels just to see that her hyperandrogenism, we reduce the hyperandrogenism and then go ahead with ovulation induction. So the results would be better, like regularizing her cycles.
And
Yes,
Dr.
Rekha?
Sapna, the second, yeah, Dr. Sapna, Dr. Bharti, what I would like to add is FSH not compulsory, but one LH is very much compulsory because that is a true reflective state of her hyperandrogenism. And if her LH, you have to make sure when you are going to induce her for ovulation induction, make sure that her LH is all has been corrected and it's at the baseline. Like we want to keep it not more than 0.5 always.
Yes,
So
ma'am.
if it is more, then it is the entire treatment will change. She will not respond to your treatment. So you may have to give her one cycle of oral suppression of OCP and then see to it that her LH has come down, and then only you start from day 2. So the baseline LH value should be normal.
Yeah.
Of course, the FSH also. So it is always better to do once. Don't have to repeat every cycle, but make sure that it's normal. And then
Baseline.
yes, once you have started the treatment, it becomes a very messy thing. She would not show up any follicles coming up.
Yeah. So basically PCOS lifestyle modification, see that she reduces at least 10% of her body weight, make her understand her problem, then regularize her cycles to bring down the LH levels to baseline with maybe 2 to 3 cycles of OC pills. And then you can go ahead with ovulation induction, provided you have seen that her tubal patency is normal and her semen parameters are normal. We should not forget, just because she's blank on PCOS, don't forget about the male partner. We need to assess them also. So, well, we come to the end of the panel discussion. Approximately 1 in 8 women aged 15 to 49 years receive infertility services. Although success rates vary by age and diagnosis, accurate diagnosis, effective therapy along with shared decision-making can facilitate achievement of fertility goals in many couples treated for infertility. Next. Next. Yes, so let us give them hope. Next slide. So the take-home message would be, do a systematic evaluation of the couple, history, physical examination, investigations, give them psychosocial support, do the investigations according to the guidelines, apply appropriate protocols depending on each case scenario, tailor-made solutions may be needed for individual couples, and be careful to document all that you do. I thank Dr. Rekha and my co-moderator, Dr. Alka Pandey, in her absence, and all my esteemed panelists for the excellent discussions. And I also thank Dr. Priyankur and Dr. Supriya Jaiswal and Dr. Monica for giving us this time. Thank you very much. Good evening.
Thank you,
Thank you, madam. Thank you, everybody here. Thank you so much.
Thank you, ma'am. It was
Thank
such
you.
a wonderful panel with
Thank you.
Thank you for the
Thank you,
opportunity.
Supriya. Thank you so much. Thank you,
Yeah.
Monica.
Thank you. Thank you so much, madam. Thank you.
Thank you.
That was really amazing that you have brushed through all the basics. You have
Yes.
compiled it so nicely.
Thank
It
you,
was very
Jairani.
interesting for all the people who are ART first line basics.
Yeah, first line
Everything you have
management.
covered, it's very fantastic. And
I
really
just
the
focused on
evaluation
the
and
first
approach
line.
is amazing.
I have
It's good.
focused just on the first line management. That's what we
Correct.
need first.
Yeah, it's good.
Thank
Really
you.
good. It's really good.
Really,
And
it
it's
was
really,
excellent.
you've taken out everything from the basics. So it was good for all the people. And definitely the delegates would have been best gained many things from your presentation.
Thank you, Jairani.
Yes, ma'am. It was a really live discussion and it was so nice. Thank you, and thank you for giving us this opportunity.
Yeah.
Dr. Jairani.
And I humbly request all of you to kindly support my candidature for FOGSI Chairperson NCD committee. I know all of you are with me, but please do work for me so that we try to for our women. I require all your support. Thank you very much.
Yes, ma'am.
Sure. All the best to you, Dr. Bharti.
Yes,
We are all
thank
there
you.
for you, ma'am.
Thank you
so
all the
much, ma'am.
panelists. Thank you, Dr.
Along with Bharati madam, let me also
Yes.
join hands.
Jairani,
Support me for the
Kalpana,
FOGSI
we've got
Sexual
many
Health
people
Committee,
here.
which is my passion. And
Yes.
I really want to do good service. I'm more than 18 years I'm in this. And I really want all your support. And we all should stand together to give this a good success. Thank you.
Sure.
We have Dr.
I also
Jairani, Dr.
request
Kalpana.
everyone to support me for Infertility Committee, which is my passion, and I've been in that committee almost more than 6 years, and I request you to support every one of us
Sure.
for our future endeavor.
Yes, let's all be together.
Yes,
Definitely, ma'am. We'll all support you, ma'am.
Thank you all.
Thank you. Thank you, Bharti ma'am. Thank you, Rekha ma'am. And
Monica.
thank you, Alka ma'am, for
Thank you,
moderating this
Monica.
panel with such a lot of take-home messages for all the delegates. I'm sure it has the starting point of infertility for all the beginners. We now move forward to optimizing outcome panel. Shatabdi, can you please introduce our moderators and the experts for the same?
Yes, thank you, Monica. Thank you, Alka ma'am, Bharti ma'am, and Rekha ma'am for the lovely panel. We move on to our next panel. The next panel is on optimizing outcomes of infertility treatment. Our moderators for the panel are Dr. Raghavendra Prasad and Dr. Abhi Koshi, sir. Dr. Raghavendra is the Director of Infertility and Fetal-Maternal Unit at Sunrise Hospital, Karnagad, and also the Executive Director in ARMC IVF, Bangalore. Welcome, sir. Our next moderator is Dr. Abhi Koshi. Dr. Abhi is the consultant in reproductive medicine and surgery at Sunrise Hospital, Cochin, Kerala, and Sunrise Assisted Reproduction Center. Sir has an advanced training in reproductive medicine from the Homerton University Hospital, London. He's published various articles and contributed chapters to various books. Welcome, Dr. Abhi Koshi. Our expert for the panel is Dr. Jairani Kamraj ma'am. Dr. Jairani Kamraj ma'am is a senior consultant of reproductive medicine in infertility and sexual medicine and director at Akash Fertility Center and Hospital at Vadapalani, Chennai. She is the president of OGSSI and the treasurer of TAPISAR. She is also the associate secretary at the World Association for Sexual Health. Ma'am has been the joint organizing secretary for ISA 2015, and she's won various medals and awards. Welcome, Jairani ma'am. We have an elaborate number of panelists today. Our first panelist is Dr. Vivek Kumar. Dr. Vivek Kumar has a special interest in infertility evaluation, male infertility, female infertility, as well as fertility preservation and sexual dysfunction. He's a consultant at Kinder Women's Hospital and Fertility Center at Ernakulam, Kerala, and at Shreyas Hospital. Welcome, Dr. Vivek. Our next panelist is Dr. Regina Munir. Dr. Regina is a gynecologist and laparoscopic surgeon and IVF specialist and the medical director of Nahas Hospital and N-Care Group of IVF Centers and the vice president of Calicut Obstetrics and Gynecology Society and the FOGSI Endocrinology Committee Kerala coordinator. Welcome, Dr. Regina ma'am. Our next panelist is Dr. B. Kalpana ma'am. Dr. B. Kalpana ma'am is a gynecologist and infertility consultant at Guru Hospital. Ma'am is also the national coordinator for the Infertility Committee of FOGSI and the post-director for postdoctoral fellowship in endoscopic gynecology affiliated to MGR Medical University and the chairperson of the Infertility Committee of TNFOG. Welcome, Kalpana ma'am. Our next panelist is Dr. Shruti Rajendran. Dr. Shruti Rajendran has special interest in IMSI, ICSI, IVF, in vitro maturation, embryo and oocyte cryopreservation. She's completed her fellowship in CMAR Edapal and she is a fertility consultant by passion, according to her. Welcome, Dr. Shruti Rajendran. Our next panelist is Dr. Radha Kolluri ma'am. Ma'am is the General Secretary of FOGSI Karimnagar branch. Ma'am has an advanced ultrasonography training under Dr. P.K. Shah in Mumbai and a fellowship in fertility from Oasis Infertility Hospital, Hyderabad. And she is also an achiever of the Dhira FOGSI Award 2022. Welcome ma'am. Our next panelist is Dr. Ram Gopal M. Pillai. Sir is a fertility consultant at Samad IVF Hospital, Trivandrum, and also a laparoscopic surgeon at Samad Hospital at Attingal and a fertility consultant at SUT Hospital, Trivandrum. His special areas of interest are reproductive medicine and minimal invasive surgery. Welcome, sir. Our next panelist is Dr. Shobha UN. Ma'am is the leading fertility specialist and endoscopic surgeon, obstetrician and gynecologist with over 15 years of experience in infertility and women's health, with a fellowship from the Kiel School of Reproductive Medicine, Germany. And she is a life member of IFS, IMA and FOGSI and presently the secretary for the Kasoga Infertility Committee. Welcome, Shobha ma'am. Yes, I hand over the further session to Dr. Raghavendra sir and Dr. Abhi Koshi sir for carrying out the panel.
Yeah, good evening, everybody. Thank you for introducing us and my partner in crime and my abettors or my panelists. And there is a person who's supervising what we are going to do also. So thank you, and thank you the organizers for giving us this opportunity. And let me just share my screen.
Sorry to interrupt, sir. Abhishek, Shobha madam is trying to join in, but she cannot connect to the audio. Can you just help her? Dr. Shobha.
Yes, ma'am.
I can see her LinkedIn, but she's trying to join in with her audio, which is not possible.
Okay,
Yes.
I'm
Sir, you can
calling.
please continue. Sorry to interrupt, sir.
Is the screen visible?
No, sir, not yet. Sir, actually, your Zoom screen is visible. Sir, can you minimize that screen of Zoom?
Hold on.
Sir, please stop share the screen.
Prasad, if there's an issue, I'll start the screen sharing.
Yeah, yeah, you do it.
Yeah.
Yes, sir. Just make it full screen, sir.
Yeah.
On the bottom side, on the bottom right. Yes, sir.
You getting that?
Sir, click on that resume slideshow. Yes, yes, yes.
Well, shall we start?
Yeah. So as you know that infertility is a common problem nowadays. Every couple is very anxious and would like to become pregnant as early as possible. And with the advent of new regulations in ART, treating an infertile couple is not like how it was previously. Obviously, when they first come to you, there are a lot of things which basically we need to discuss. Many of them may or may not be aware of what is correct and what is not correct. So with those points in view, let's start this presentation. When the panelists, any of the panelists, when the patient first comes to you, what are the basic things which you would ask them in relation to your questions?
Can I take it, Dr. Raghavendra?
Yeah.
Yeah, thank you for the opportunity. Yeah. First thing, we would like to ask the couple who are coming to the infertility department after their basic information like the age and number of years of marriage is how many years have they been staying together or how many years have they been trying for a pregnancy seriously. In Kerala, especially, even though many couples have been married for many years, They might not have been staying together. The one partner might have been in a foreign country, or he might have been working outside the state or in the army, and we see so many patients like that. So even though the duration of infertility might be in years, their duration of cohabitation might be in months only. So that is one thing which we ask in the primary evaluation itself.
Yeah,
And
so so when you're coming to that, the cohabitation, when you talk about it, you will have to look mainly at the coital practices, which is commonly practiced by the couple. What exactly would be your advice regarding what the fertile window or the fertile period and how frequent they should have intercourse? And what are the few pointers which you would suggest to the patient couple in view of the coital practices which they would undertake?
Yeah, shall I pitch in, Dr. Raghavendra?
Yeah, please.
Yeah, there is a good point here brought it up, because whenever, as Dr. Ramgopal said, all these initial history and all this marital history has to be taken care, and as he rightly pointed out, this coital practice of staying together will be the first point of history to enter into their coital practices, and asking them properly about what are the exact word I used is, do you have any challenges in your sexual relation, like any kind of coit this one, or I'll ask them generally, do you consider, both of you consider it as satisfactory? But regarding this coital window and the fertile period, one thing I would generally tell the couple is not to excessively focus, because we know these days women are very educated and empowered. They use all these apps to track their fertility period and the apps, and they exactly have the contact during those days, and rest of the days nothing will be happening. They will be sleeping on different different directions. So one thing I always try to say is that make it a point that your sexual practices are not only focused just for the pregnancy, it should be a part of your life, so that every time when you are focusing too much on the fertile period and your ovulation days and all those things, the stress will add on. Every month the stress is going to add on. So this is one point I would like to make it a point that I would advise all the couples.
So I think, Dr. Vivek, you have mentioned very rightly, because when you ask a couple about the sexual frequency, it is never focus them on the period of fertility. So many of them says, Doctor, I've been married 3 months. We are exactly doing between 10 to 20 days, but nothing happens so far. So the number of months is hardly 3 months. And also the time they are taking is the fertile window. That's what they feel. But if you look into the real data of the sexual coitus frequency and the fertility outcome, people who do more than 15 to 18 times a month have 83% chances of getting a pregnancy. Whereas people who do sex during the fertile peak, as they feel the 10 to 15 days, they have 12% only they get a pregnancy. And if you exactly see if the couple, they do sex on that ovulatory day, they have only 4% chances. These are the data and research says about the sexual frequency and the fertility outcome. So it's always, as rightly pointed out by the moderators, that the frequency should be more. We should not ask them, because if they are more towards the outcome, their stress level may make their performance very much bad. Their anxiety performance, the erectile dysfunction, the sexual inefficiency, everything will happen. And that itself can cause infertility issues, right?
Yeah. Yes, madam.
Shall I add few points?
Yes, madam.
When we are thinking about natural fertility, we need to think about the age of the patient and also the cycle length. If we need to ask what is her regular cycles, if it is irregular, then ovulation will be very erratic. And if the patient is having very short cycle, she is maybe a case of premature ovarian insufficiency. So her ovarian reserve should be tested according to the cycle length. we need to advise her which is the most fertile period, even though it is really stressful to advise them to go for sexual intercourse only during this ovulation window. But we need to tell them properly, this is her ovulation window. Ovulation period is not uniformly between 10 to 20 days for all the patients. It varies from patient to patient. We have to educate the patient accordingly, and we need to counsel the patient that stress also can interfere in fertility in many aspects, not only in fertilization, but also in implantation. So we need to counsel the patient and give proper window, and then educate them. It is really important for them, I think.
Thank you, ma'am. Abhi, can we have the next slide?
Actually, the slides are not moving, I think, sir.
Yeah. The next one, Abhi. Next one. What do we think of, is there any role for basal body temperature in our, in explaining to the patients about, when we are asking them about the days of, for them to try?
Actually, it adds on more stress, I think.
Yeah. Can we have the next slide, Abhi? Because it's basically it is physiologically based on a 5% degree increase, which occurs usually post-ovulation. So we would have already missed the fertile period when we asked them to follow this basal body temperature, and it's actually quite stressful. And routinely, we normally do not follow. These were all there previously. So as of now, I think we better not advise this kind of testing for patients who are trying to conceive naturally. Now, many a times the patients do come to us asking us questions regarding when they should have intercourse, how frequent they should have intercourse, regarding the positions, and do they need to take lie down after intercourse? I mean, these are some of the very common questions these patients do come and ask us during the particular time. So any of the panelists, can you enlighten on, is there any role on importance in any of these factors?
Actually, many a times the couple come to us and tell that it may be premature ejaculation, or the semen which leaks out after sexual intercourse. They are more bothered about it, and we need to tell them it is we need ultimately one single sperm which has got very good motility to reach the ovum and fertilize the ovum. So we need to counsel them. It doesn't make a great difference as far as their fertilization or pregnancy rates are concerned.
Yeah, Abhi, the slides are not seen, Abhi.
So I want to add up one more thing regarding the spillage of the semen,
Yes,
if
madam.
I'm allowed. So as it is, there are two things that you should understand. Basically, the sperms cannot survive in the acid vaginal pH. So after the coitus, once they are deposited in the vagina, the natural tendency of the sperms is to travel inside the cervix because they are sucked inside. From the seminal pool, the sperms are sucked inside because they travel immediately to the alkaline pH inside the vagina. So the acid pH of, the cervix, the acid pH in the vagina will not allow the sperms to survive. So the active motile sperms will then automatically enter, and the excess seminal plasma which is coming out doesn't have much of a sperm sometimes. So we should tell the patient that the spillage, need not worry about it because the active sperms could have gone inside the cervix. So that is a very important point that we should know from the biologic basis of the sperm survival, which cannot happen in the vagina because of the acid pH of the vagina. That's one important thing that you should add up in your counseling from the scientific point of view.
Yes, madam. So that's why we said there's no scientific basis in engaging for intercourse during any particular time of the day. There is no benefit in coital or post-coital position. Remaining supine does not facilitate sperm transport, and there is no relationship between orgasm and fertility. Now, the next most common thing which we look at is when the patient comes to you is regarding the diet. What can I eat? What I should not eat? What I should avoid? So can we start? What is the ideal fertility diet? Any of the panelists, please?
Yeah, diet is actually a very a crucial thing, even though we know that we generally you can't have, as we give this folic acid and antioxidants and all those things, whatever we give, ultimately giving all this bunch of nutraceuticals and vitamins, the final question patient before getting up from the chair is about the diet. Invariably they'll ask. So definitely it has become like a norm that you have to advise some diet to the patient. But generally what I used to give to my patient is that we say that because all these environmental pollutants and toxins are there in whatever we eat. So unless and until we don't have any control on whatever we eat, because none of us are cultivating the own vegetables and fruits are eating. So whatever we are eating may be containing so much of environmental pollutants and pesticides and all those things. But things are which are not under our control. There is no point in stressing on that. But generally, I would like to say them to have a more of this protein-rich diet, green leafy vegetables, and try to reduce the calories generally. And more than diet, I would ask them for a good lifestyle, I mean, healthy, active lifestyle also with exercise.
Yeah. So basically, when you look at it, if you see that all South Indian people who are from South will have a load of tomatoes and potatoes and everything which we eat. And the highest pesticide containing vegetables mentioned are again tomatoes and potatoes. So we'll have to, that is something which we'll have to look at in future. And also, Abhi, can we have the next slide, please? A folic acid dose of more than 0.8 milligram is recommended, because when you give this folic acid, there is a increase in actually a pregnancy rate when the patient tries spontaneously. But the role of coenzyme Q10 is limited in increasing the likelihood of pregnancy. Now, as Dr. Vivek mentioned, the next most important thing which comes to you is when we look at from the point of view of body weight or exercise. So when you have the image, what you see in the picture, you have an obese man and an obese lady. What would you advise regarding their fertility status and what you would advise them to do? Yes, Dr. Shobha. Anybody wants to answer?
Sir, can you hear me, sir?
Yes, please.
Yeah, so actually obesity is a main concern regarding the fertility. There are so many studies which shows that obesity itself contributes to the fertility. So obesity in a female can contribute to anovulation and hormonal imbalance, thyroid problems, all those things. And in a male, it may leads to a difficulty in ejaculating, difficulties in difficulty in intercourse. So lifestyle modification gives a lot of relief in the fertility, and so many people will conceive with the weight loss and exercises. So usually whenever I see obese male and a female, I advise for a weight loss and lifestyle modification. With these, so many of them have conceived, sir.
Okay. Yeah. So ACOG at least recommends at least 30 minutes of moderate exercise per day, at least 3 to 4 times per week. But mind you, too much of exercise, especially bicycling, because I think nowadays everybody is crazy about cycling, and more than 5 hours per week, if you cycle, please do, because that will help us a lot in improving our practice. And next, as we know that the current younger generation is the extremely fat generation. They like to enjoy, they like to party, they like to drink. Now, what is your panelist opinion regarding alcohol?
Effect is not been clearly established, I think, for alcohol, but heavy drinking is better to avoid. That may cause decrease the sperm count, and sexual frequency also decreased.
Yeah, correct, Dr. Yeah.
Motility also will be decreased.
Yeah.
Yes.
Sperms will also be decreased with a lot of consumption of the alcohol. So,
so better to avoid when attempting for pregnancy.
Yes. So practice committee of ASRM says, okay, you can drink 2 pegs at least a day, not more than that.
Yes, chronic alcohol dependence is better to avoid.
Yeah, but there is no other evidence suggesting that alcohol may harm the sperm concentration or the other factors, as Dr. Rajina rightly mentioned.
But
Can we have the next?
Yeah, I think better we don't put out this guideline to a patient. Probably he would have stopped. Probably he would have somehow forcibly stopped drinking. No, he would have been drinking, but for this purpose, he would have been stopped for the last 6 months, at least for the fertility purpose, totally teetotaler. But again, this can give him a this one. But definitely,
Yeah, this is not for the patient. This is only for the gynecologist. Information.
Yeah. And especially in case of the males, the alcohol can cause an increase in the desire, but in the trial, when it comes to the thing, it can impede the normal coitus only. So that way also it can reduce the fertility in those people. Yeah.
And high level of caffeine consumption also we have to reduce. More than 5 cups per day is not advised.
Yeah. Correct.
So generally another point to be added is if there is an alcoholic, they have a liver problem that may add on to the hormonal changes of the estrogen level in the men that can cause an impact on the seminal count and other things and sexual performance also. So all these things definitely 4 pegs a week definitely will have a low count. That is what they say. So sir, we are not supposed to do 2 pegs a day. Sir, Raghavendra sir. Definitely your patients are lucky. Your male patients will be liking to come to see you because you give them a clearance of doing a green signal to have their drinks. That's a one way of attracting them.
Not to forget the effects, the effects on the fetus, including that fetal alcohol syndrome, which can result if the female is also continuing during pregnancy, even though he might be using wine or something.
Yeah, Abhi, can we have the next slide, please? Now, the next common thing which we see in Kerala is, when we look at the whole of India, you see the next common factor. This is what generally we see. So what would you opine regarding this particular habit?
Strict no. Dose-dependent defect, decrease in the fertility, and as well as the semen, as well as the oocyte parameters, improvement, increase in spontaneous and other miscarriages and fetal congenital anomalies. So strict no. No point in reducing, you have to strictly stop it. That is my advice to my patients. Including passive smoking, not only active smoking shouldn't be present. If you are trying to conceive, don't be near a smoker at least.
Okay. Again, this is I'll talk about only the last sentence. There is limited evidence regarding clinical infertility, but cessation of smoking is advisable to increase fecundity. This is not my words. This is what ASRM has given as a practice committee guideline. So can we have again the next slide? Now, these are the next newer pictures which have come, newer things which have come, what we call as endocrine disruptors. Now, this is again gaining importance because these have been shown to affect the sperm and the ovum quality. So if you look at it, I'll just go through this. There's maximum pesticide residues in grape, tomato, and peppers, which can cause decreased sperm motility and morphology. You use cosmetic, fragrance, sunscreen, detergent, shampoo, conditioner, lotion, and also toothpaste, which can affect the sperm quality. If you are drinking a lot of bottled water, using a lot of processed food, lot of achar bottles, ready-made achars, it can bring, and plastics, it will affect your, because of bisphenol, it can affect oocyte maturation and quality. So these are in general regarding the basic factors which influence natural fertility. Once the patient has tried and you have given all types of medications and they have not conceived, the next probable treatment option which you look at would be IUI. So to take you through the stream of IUI, I would call on my co-moderator, Dr. Abhi Koshi. Dr. Abhi, over to you.
Yeah, good evening, everybody. Now, IUI is something which is very treatment, and most of our patients also know so much about the treatment that they come asking for you for that treatment. So we have this couple, a 34-year-old lady who's been married for 3 years, and like what we discussed earlier, they have not really lived the 3 years together. Husband is older, she's got regular cycles, a reasonably okay BMI, and a sperm count which is slightly on the lower side, but not really, really low. So they come for you with a request for IUI. So Dr. Shruti, what do you think about this couple? Are you something you would be preferring IUI for this couple, or would you be recommending something more than that?
So I would be asking him how long is his stay with a wife. If it's for more than 2 months, then we can try a cycle of conception and then advise her for IUI. Otherwise, the sperm count is reasonably normal and she has regular cycles. Her age alone is a factor, which is 34 years. So I would check her AMH and her ovarian reserve. And if everything is normal, 1 cycle I'll wait. If there is a poor ovarian reserve or he is not staying here for more than 1 month, I would directly go for IUI.
Can't hear you.
Sorry, thank you, Dr. Shruti. We're just having a lot of thunder and lightning here. That's why I just muted myself. Okay. So, Ram Gopal, when you look at IUI for this couple, are there any markers which you feel are important, which tells you, okay, these are the patients who are likely to have a better success compared to, say, any average patient? What are those factors which you think helps you in getting good results?
Yes, sir. Primarily, it would depend upon the age of the female partner. If it was a younger partner, this patient's age is around 34, slightly on the higher side, but she has only been married for 3 years and they have co-inhabited for half an year only. So, age of the patient will be the first thing, and secondly,
2.5 years, no?
That two
cohabitation, 2.5 years, no?
He's living abroad.
1.5 years only. So
husband is living abroad.
Would be the first thing, and secondly, with the age or with the help of AFC, or as our doctor has mentioned about AMH, we can see the ovarian reserve, so we'll know how much time we have or how much time we can afford to lose before moving on to a treatment like IUI or the next step. And thirdly, as we have shown in the semen analysis itself, the count is normal, but the motility is on the lesser side. But when you come to the total motile sperm count, you can get enough sperms. Around 5 million you will get from 25 million per ml and 20% mortality. So you can do IUI in this sort of patient, given the fact that they haven't stayed together for long enough or they haven't tried IUI before. And it will depend upon whether the husband is going to stay here. Then we can give that time. Otherwise, we can move on directly to IUI or ask him to store samples so that we can decide even if he is not here.
Ram Gopal, is there a simple test where you can actually decide whether the semen sample is suitable for IUI? I mean, what else can you do in the semen assessment as such? Rather than just looking at the semen report, is there some calculation or
we can try and calculate the total motile sperm count from the semen analysis sample, from the concentration, from the percentage of motility and all, and and the volume of the semen sample. So if the semen sample, in most of the studies, it has been proven that semen samples more than 3 or 5 million will give you good results when you are planning for IUI. And if the samples are having less total motile sperm count, you plan for IVF. And so total motile sperm count would give you a basic idea of what to decide from the semen analysis.
Well, Dr. Kalpana, that sort of gives you a good idea. In your practice, do you actually do a tubal evaluation for all your patients before IUI?
Yeah, definitely. At least by HSG or by SSG, we need to confirm tubal patency. If you have done so many IUI before, and if the patient pays, and then if you do tubal patency, if it is blocked, the patient would ask, if my tubes are blocked, why do you subject me for IUI? That's a logical question. Then we don't have an answer for the patient, and in front of the court of law also we don't have an answer. we need to confirm tubal patency at least by simple test, even by sonosalpingogram that confirms at least one tube is patent. Then only we have to go for any kind of mild treatment. As far as this case is concerned, we are talking about the success rate. It is not only the total motile count, male partner, we need to think about the reason for infertility. Many a times, if it is anovulation and also unexplained infertility, the possibilities of pregnancy is quite high compared to endometriosis or sometimes any other factor. We need to think that anovulation has got a very good success rate, unexplained infertility, very good success rate, endometriosis, least success rate. We need to counsel them before starting that. Tubal patency, definitely I will go for that.
So the predictors of the success, the predictors, can I add something? So to put forth, the predictors of success of an IUI depends upon various predictors. One is the first, as rightly pointed out, by the age. Younger the age, better the fertility. And the duration of infertility, if there is a lesser duration, they have a better success. And in the cause of the infertility, as rightly pointed out by Kalpana, if endometriosis and other conditions, they have less chance, whereas unexplained infertility and moderate male infertility, they have a better chances. And then, of course, very important is the procedure and the process and the technique. These are the next important one. For your general category, we have to see all these predictors. And then depending on the patient specific, their reserve, their tubes, their uterus, other condition has to be evaluated. So to optimize an IUI, we have to look into all these predictors. Then only you can counsel the patient that what is their success rate per cycle with an IUI, which can give them a holistic approach to this condition. Otherwise, with one IUI, if they think that is the ultimatum, then you will be landing up in a stress of when the patient comes and, oh, doctor, I failed, why this is. So you should have all the predictors to put forth as a proper comprehensive way to assess the predictability, which is very important when you have a IUI cycle plan for a couple.
Thank you, Dr. Jairani. In fact, we do get a lot of patients who expect 100% result in the first cycle. That's not very uncommon. And if you tell them it's only 10 to 15%, they might be running to the nearest clinic. So just to summarize,
Abhay, for us in our center, we do first IUI without HSG. Only if it fails, only we will do HSG because it's a painful procedure.
Even I would like to add on to this. I usually don't do a tubal evaluation universally for all the patients before IUI. Even I do at least 2 cycles of IUI. And before 3rd cycle, I would discuss with them regarding the tubal. As Madam told, it's a very invasive and painful procedure. Unless and until there is a high index of suspicion to see that whether there is a endometriosis or cues of PID. And obviously, if the age is less, definitely I also will not do a tubal test before at least 2 cycles of IUI.
I just want to add up, Dr. Vivek and other people, I just want to add up, if it is a male factor, for example, an azoospermia, a donor procedure, or a moderate male factor, if that is the criteria, and if you feel that everything looks normal for the women, you can say that way. But don't put it as a blanket thing that I won't do first 2 cycles.
No, madam, by ultrasound, we can know that many of the things we can know by the ultrasound.
I know, but
only if hydrosalpinx for.
See, why the indication? What is the indication for your IUI? That is very important. If your indication is an unexplained, when you call it unexplained, you will classify them after doing all the tests. Then only you will know as an unexplained. Then only you will subject them for IUI. You can't take IUI for everybody. For a donor program, you can do without a HSG.
And also for sexual dysfunction.
Or a IUI, if there is an indication, it should be included a tubal evaluation.
Yes, and also for IUI, the morphology is also very important.
No, but even ASHRAE guidelines, which is saying about polycystic ovarian disease, where the tubes are not definitely involved, maybe in endometriosis tubes may be involved, but even in PCO guidelines, ASHRAE and ASRM guidelines correctly pointed out that tubal evaluation is mandatory before you go for any kind of mild stimulation. Even in a male factor, if you think that the patient has got a mild male factor. For that, you are going for ovulation induction IUI. What guarantee do you have she doesn't have tubal factor? You can't just like that judge your tube that it is patent. How do you do that? If you have a hugely enlarged hydrosalpinx, obviously you can be very sure that the patient has got a tubal disease. Otherwise, mild tubal disease, how do you confirm that the patency is there? I don't think without confirming patency, you can't advise even natural cycle, ovulation induction with natural try also. I don't think we are wasting patients' money, energy, time, and also our time. Without testing tubal patency, you can't just like that delay the duration, I think.
Madam,
the difference of opinion is basically coming because of the reason that the pickup rate for tubal disease is very different from different parts of the country.
Yes.
Now, when you're looking at Western guidelines, you need to understand that PID and tubal problems are very common there. In my state, tubal problems are rarely seen. You might do 100 HSGs and you might find one abnormal case. That is why in certain parts of the country, you would not do HSG as a routine because the pickup rate is so low. But if I move from this district to a different place where you have tubal problem disease is much more common, definitely I'll put that as my first test before I go for everything else. So I think it's a geographical change which is there. Ram Gopal, you need to add something.
And sir, in a set of patients where there is a history of pregnancy loss or DNC or ectopic or something, before you proceed for IUA, you can do. Otherwise, I don't think it is recommended for everybody before you are doing an IUA, tubal patency testing.
Right. So we'll just close that topic because it's a very controversial topic and move on. So like what we said, age is an important factor. We know that the best results are with unexplained infertility and the worst with endometriosis. And what we need to also understand is that this duration of infertility is very important. A couple with a very long duration of infertility might have a lower success rate. And these are patients who might actually benefit from something better than IUI. Now, the second thing which we all think about is what stimulation should be using for IUI. Dr. Shruti, what is your personal choice for stimulation for IUI, or do you have different stimulations for different patients?
Depending on what the patient is. If the patient is PCOS, I would, and she's having regular anovulatory irregular cycles, then I would go for an ovulation induction with letrozole or preferably letrozole because it will lead to monofollicular development, and I would consider IUI. And if it's a normal regular cycles, we can try with natural cycle IUI itself if she has reasonably tried for 6 months, cohabited 6 months.
Dr. Shobha, what do you prefer to get in terms of number of follicles with your stimulation? I mean, do you have a upper limit or lower limit? Dr. Shobha, are you there?
Yes, sir. Yes, sir. Yes, sir. Sir, can I answer? Sir.
Yeah.
In normal ovarian reserve, I would like to try. I will see the previous history of ovulation induction. With if she's already been induced once, I'll see what was the response with the clomipene citrate or letrozole if they have used. If there is endometrial thickness and number of follicles were not good with the tablet, I would like to change the stimulation drugs. If they've already used clomipene citrate and endometrial thickness is very less and response is bad, then I would like to add letrozole. If straight away patient walks into me, if it is a PCOD patient, then I would like to add letrozole, extended letrozole protocol. If a normal ovarian reserve, I would like to stimulate them with the CC, clomipene citrate. Both of them have got a very good result actually. But in case if as the cost of IUI is little more compared to TSI cycle, I would like to add gonadotropin also. I will counsel the patient regarding the cost of the gonadotropins required for the stimulation, because study shows that the follicles which have been developed with the gonadotropins and the endometrial quality will be good with the gonadotropins compared to tablets. So anyhow, we are doing it sincerely, and the patient is also is ready to spend the money. Then I definitely prefer gonadotropins plus IUI for a better results.
So to put forth, I think I would rather suggest to put forth everything together. Shobha and Shruti, you should start your plan. So the strategy, what they've given by the studies is, if you have 2 or at the maximum 3 good quality follicle, then that has a better successful outcome. So you should plan only for 2 or 3. That is the best outcome with the IUI. You need not go for any protocols which gives you 10 follicles or 10, 15 follicles or monofollicle. If it is 2 or 3, the success rate with the IUI is optimized to be better. At the same time, when you start with the patient, as rightly pointed out, if they have an earlier simulation done with an ovulation induction, you start with the medical ovulation induction and see how they respond. That is oral ovulogence. And 1 cycle you do with that. The next cycle, if they respond, you continue for 1 more cycle. And then 3rd cycle, you can add up a gonadotropins if they fail. So that is a usual thing that we do if there is a proper response. So you aim to get 2 or 3 good follicle with a good endometrial development around 8 mm. So that should be the planning for your optimizing a success for an IUI. That is a very important thing that you should know. And never start immediately with the gonadotropins. As you rightly pointed out, medical oral ovulogence, and then you go for the injectables, and then you can give a combination. And of course, if they, with a good response and the previous cycles failure, you can add on to it, whatever the success. To add on to it, you can have your HMG or Recagon, depending on the patient's profile.
Any preference for gonadotropins?
Sir, can I ask some doubts, sir? Sir, these 2-3 follicles, people say how to get these 2-3 follicles. Ma'am, I've tried everything. I've tried ovulogence, I've tried injections with ovulogence or only injections. It's very difficult. It depends on patient's body behavior than our drugs, I think.
So ideally speaking, will you be doing the day 2 scan? You have to see the antral follicle, which is the dominant, how many that you feel. So if it is very high as a PCOS, you always start with the oral ovulogence, always start with your either clomiphene or the letrozole. And then you monitor her. Maybe they may need 2 or more cycles. You have to follow them, because infertility doesn't end with 1 or 2 cycles. It is a continuous process. It should be at least 4 to 6 months. She will be under your care. At the time you can plan, you can think, you can have the baseline, you can assess each patient, and then only you can have a better success.
No, I just wanted to ask the seniors, is there any protocol? I keep asking all my seniors.
See, no patient, see, that is what the standard.
Follicles, 2 to 3 follicles. Even I am behind this 2 to 3 follicles.
Yes, I'm telling you. Yes, first to start with, sometimes you get, with the first stimulation itself, you get 2 follicles. Then that patient is responding well to your stimulation. So continue that. She may conceive in that same cycle also. So you are starting with a clomiphene 100 milligram. She's getting 2 good follicle. That's ideal enough. So subsequent cycle also you can give the same, but you should think of the endometrium. Sometimes the endometrium will not be the same as in the next cycle. So in that way, probably you have to plan. Every cycle is a cycle. You have to think of that patient. There is no standard protocol. But when you are doing an IUI as a whole in a center, start with the minimal ovulogence, see the response, and then plan the next cycle. Every cycle you have to plan like that. So to start with, you have to give medications. If she responds well for 2, continue the same. And you have to think of the endometrium response also in that way. So that is how you should plan. It is not a blanket wall at this procedure. This protocol will give you 2 follicles for this patient. No, it cannot be. So it is all your experience and expertise of each patient seeing. Every patient has to be individualized.
Madam, what is your take on adding steroids to oral ovulogence and HMG?
No, that is only for people who are a PCOS who has a 17-hydroxyprogesterone value which is less. That is only for that type of a PCOS who never respond to your routine clomiphene. You can add on to the DEXA, your steroid. Those are the couple, those are the women who respond to the steroid. Regularly don't put for all people.
Shall I add few points? As far as ovulation induction is concerned, we have clomiphene citrate and
letrozole. But studies have proved, and we have also seen that ovulation is better with letrozole, and pregnancy rates are also better with letrozole. There is no resistance as far as there is no complications, anti-estrogenic complications on the endometrium is very less in letrozole compared to clomiphene. So letrozole should be the preferred drug, of course, as far as it's concerned. It is considered as a first line of management. So if the patient ovulates and then she fails to conceive, you can consider few cycles of ovulation induction with letrozole also. If she fails, then gonadotropin is the next choice, and instead of going for oral vobulogen and gonadotropin, you can go for gonadotropin only cycles, and it has been proved that continuous daily use of gonadotropin will improve the pregnancy rate. And you are thinking about 2 to 3 follicles. Literature-wise, we need to shift the patient if she has got more number of follicles to IVF, but it is really difficult in the practical life to counsel the patient for IVF when she is mentally and physically, financially prepared for IUI. Shifting the patient to IVF is going to be really difficult, and you should be able to manage even mild ovarian hyperstimulation if she gets 3 or 4 follicles. It may not be sounding good, but practically it is difficult to cancel the patient when she gets 3 or 4 follicles. She will ask you, will I have 1 or 2 follicles in the next cycle? The answer will be really, really difficult. So we have to counsel. There is a possibility of mild hyperstimulation, and there is a possibility of multiple pregnancy. But still, we have to get the opinion of the patient, and the dosing of gonadotropin we have to decide depending upon her antral follicular count and weight of the patient. So low dose has to be started, and it may be very gradual. And ultimately, we have to aim at 2 to 3 follicles. Sometimes it may not be possible at all cycles. We need to counsel the patient to accept the minimum risk, or to cancel. The patient would not go for cancellation of the cycle. She has to accept the mild risk of hyperstimulation or multiple pregnancy, whatever it is.
And I think it's a balance between trying to get the optimal number of follicles as well as making sure that you don't have a high risk for multiple pregnancy also. I'll just move on. Any personal preferences on the type of gonadotropins, recombinant or HMG? Anybody can answer that.
The preference of gonadotropins is, I think we have already agreed to a point that IUI being a first line treatment in the ART, we have to keep the cost down. So definitely HMG would be a better choice in that aspect. But HMG is better too for getting results for IUI.
But again, depends on if we are going for a chronic low dose step-up protocol for resistant PCOS, then that time we have to stimulate them with recombinant FSH.
Shall I?
Recombinant has the
Not
advantage.
needed.
Shall I add few points? As far as the gonadotropin is concerned, we have FSH, HMG, recombinant, urinary, n number of drugs available in the market. Previously, recombinant was selected because of its purity, and as far as the pregnancy rates are concerned, it is marginally high in recombinant. But recent studies had concluded that the pregnancy rates are almost similar in recombinant preparation and urinary preparation. So HMG has got a comparable pregnancy rate. Previously, recombinant was used because it was thought that HMG would increase the hyperstimulation rate. But recent ESHRE guideline has concluded that the hyperstimulation rate is not high with HMG. And recent papers had concluded that the pregnancy rates are marginally higher with HMG Even though right now we can't just like that recommend HMG over recombinant FSH, but the pregnancy rates are comparable. Considering the cost, all those things, I think HMG would be preferable. That too in IUI cycle, when we consider the cost of the cycle also.
So we can add on, we can take home message two things. One is all the gonadotrophins behaves almost normal in a normal responder. But if you have a PCOS patient, you should always think of giving them a recombinant even for your IUI cycles, which will give them a monofollicular, and also it may avoid a hyperstimulation. But in a normal responder or a male factor, which you can give a HMG that reduces the cost and gives the same results. But it is the type of response which you think in a type of patients, especially PCOS, better to go for a recombinant, and the low dose step-up protocol will be the ideal to get 1 or 2 follicles.
Dr. Vivek, your comments on what trigger and timing of IUI?
Trigger, in case, definitely trigger again depends upon the nature of the patient, and if she is found to be having a if there is a single follicle or even 2 follicles, and I feel she is not a high risk for a hyperstimulation, definitely HCG is my HCG 5000 is my choice for a trigger. And if she's a high risk category for OHSS, then I would like to give a agonist trigger, the NRH agonist trigger.
And your timing for IUI?
Timing for doing the IUI is definitely for actually for doing the procedure, I don't keep any particular timing, because yes, for IVF I will keep a trigger for the particular time and plan the oocyte pickup. But for IUI, whenever the patient is coming to see for the ovulation scan and she's in the clinic, I will give her HCG injection and ask her to come for the after one day after for the IUI.
You do the IUI next day. Thank you.
Next.
Any comments on use of antagonist for IUI? Does anybody use it in the routine practice?
No, it is not a cost-effective way of treatment, because actually it will reduce the premature LH surge, but it is not a cost-effective way of treatment.
Yeah, I'm just asking if anybody is using it routinely in select situations.
No, we are not using.
Not being used routinely, but it can be used in 3 specific situations. As Madam mentioned, one is premature LH surge, and secondly, when there is an endometrial and follicular dyssynchrony, you want the follicles and them to be growing together, then you can use this. And thirdly, when you want to avoid IUI on weekends also, you can probably use this.
Yes. So if you are having marriage or some function, you can respond.
And so many times when we plan IUI, suddenly we tell patients to come tomorrow, and tomorrow if I do scan, it would have ruptured. So next cycle, I prefer giving antagonist so that I can plan IUI properly. And I have a contradictory statement regarding the trigger and the IUI timings, sir. Trigger is, it depends on how the follicle is. If it is a gonadotropins, I would like to give a trigger at around 16 mm. Once the follicle reaches 18 mm.
18 mm.
16 to 18 mm. But so many times I've seen, ma'am, 18 mm, I will miss the bus. See, then
so
if
probably your measurements, you have to be little more. If you poke your probe little tight, your follicular size will be little less. So if you be a little relaxed, your follicle size will be big. So there is always a user thing. So you should have your way of your usage to check the proper level. So ideally speaking, for a IUI cycle, it is best to go for an 18 to 20 mm. That is always the stimulation. But for IVF, we can go at 18. But for IUI, they say it's 18 to 20. That's the time you do for the HCG trigger.
For HMG cycle, it is 18 to 20. And for clomiphene or letrozole cycle, it is 20 to 24.
Ma'am, what about this timings, ma'am? Timings of
Timing
IUI?
for single IUI, 36 to 40 hours, and for double IUI, 24 and 48 hours.
Ideally speaking, 1 minute. Listen to
Confirm
me.
ovulation.
Yeah. So ideally speaking, the IUI timing can be, there are two ways. There are a lot of studies which have said the timing are the 34th hour and one after post ovulation, that is the 48th hour. But any IUI planned close to the ovulation will give you the best success. So one best IUI close to the ovulation. So if you are monitoring, if you have your own ultrasound, you will be monitoring morning and evening. If you see the ovulation happening, then you do the IUI, that will give you the best success. Instead of making that, sometimes it is very cumbersome to have a scanning. You do 34th hour, one IUI, and then you check the ovulation and do one more IUI if there is a thing. But there are all studies, all the research have proved that that nothing has a better success. Both are almost the same, but anything close to the ovulation is the best one.
Madam, when will you give the trigger for 34 hours and 48 hours?
Pardon?
When will you give the trigger?
Trigger is one size of optimum, the follicular size when it is optimum around
No, timing, madam. Timing of trigger.
Anytime when you give, you calculate.
No, you want to do 34 hours and 48 hours.
Yeah, when you do in the morning, you have to ask them to come the next day evening. It is all your clinical practice, how you do. When the follicle size is that, you give that and calculate the 34 hour, ask them to come.
Ma'am, senior persons, I have one question. See, what is your experience while doing IUI? It is post-rupture is got a better result or a pre-rupture has got a better result?
That's what, anything close to the rupture. I always do a post-rupture. We have a center exclusive for the fertility. For 30 years I'm practicing. So always we check the ovulation morning and evening. So once you trigger that time, they come in the previous day, there's no rupture. In the morning you rupture, you do the IUI close to the time. They have a better success. But in places where the patient cannot commute, they cannot come, you ask them to come on the 34th hour, check for ovulation and then do an IUI. If there is, then they ask them to come the next day, check the ovulation and do one more IUI if they want. That's it. It all depends upon individual approach, your availability, your patients come, their convenience, everything matters.
So simulation, as we all discussed, is important, and the timing of IUI also helps. But we also know that you need to keep an eye on the multiple pregnancy report. There have been a lot of data on types of gonadotrophins and all, but the general consensus is that whatever use, the results are good compared to just oral ovulogins. And there's no difference between urinary and recombinant. Antagonists will not improve pregnancy rate, but there are some studies which show a difference, but again, they are very small studies and you should be very selective about using it. Now, the size also, the data is that there's a lot of conflict in data, and many studies have shown that the size, small difference in size does not make much of a difference. And any IUI between 36 to 48 hours, if you're doing a single IUI, is good enough. There is, I'll skip this thing, but it's again important to make sure that all your paperwork is complete with the current guidelines, make sure that a proper consent form is taken. And if you feel that there is an issue about who the husband is or the wife is, you can put an ID proof also to make sure that you're doubly safe, but it's not a standard recommendation. Now, is there any recommendation you give to your patients, Dr. Shruti, about abstinence in terms of IUI?
No, sir. I would like to ask the patient to be having her intercourse along with IUI, which the ultimate motive is to increase the number of motile sperms during ovulation. So it is always better to have intercourse. Along with that, we can do IUI. There is no need for a particular number of days abstinence, which will
I think that's very important
because
many patients, they just stop having sex when they are doing IUI. So you have to tell your patients that they should have regular intercourse, and that helps, especially when you have an early ovulation or something and you miss the bus. Any specific recommendations where you would definitely like to do an double IUI, Dr. Ram Gopal?
Sir, in some we are doing single IUI for most of the patients in our center, but double IUI will be considered for 4 subset of patients. When we have a doubt that whether the follicle has ruptured or not, those patients might have an advantage if we use double IUI. And in cases whether donor IUI used, so that there are no more available sperm from the husband's part, which can help in those patients for increased pregnancy. When the husbands are out of town and they have stored samples, then we can use double IUI because that might increase the chances. And when there are substandard male semen parameters, these are the 4 conditions where we might consider double IUI. Otherwise, we do a single IUI for most of our patients.
Now, we are aware that cryopreserved sperms have a shorter half-life compared to fresh samples. And because the new law is about using only cryopreserved samples for donor IUI, would you be recommending double IUI for all donor samples? If you keep the cost part apart, anybody can answer that.
Not for all.
Not for all. It is need not be all. So there is no standard recommendation like that for the donor. You have to go for double IUI. It is a good one proper IUI post ovulation or close to ovulation is ideal. And if the patient, sometimes they may insist, if you fail 2 cycles of donor process, they will be asking for double IUI. And then you can tell them that you can do it, especially for the donor. It's not a standard recommendation to have double IUI for the donor program.
Yeah, that's a nice answer, because again, we are talking about costs also. 2 IUIs definitely will cost double. So you have to be very careful about advising your patients. Now, this is a data about abstinence. Again, shorter the abstinence, better the semen in most cases. And it's also important to make sure that your lab is equipped well so that you don't waste too much time after the semen is collected. Processing time should be fast, and you should be doing IUI as early as possible without compromising on the quality of preparation. Anybody who uses ultrasound during IUI, have you had any better results, or you find it easier to do IUI?
We find it easier to do IUI, sir, because we'll come to know where is exactly the os is in antiverted and retroverted patients. So for our satisfaction, sir, and the injury will be very minimal. And patients also feels comfortable with ultrasound. We can show them.
It is always better to go for ultrasound guided IUI, but practically it is not possible. And simple IUI will be sufficient. And there are a few contradicting studies. It's not like embryo transfer, which should be very smooth, and uterine contraction should not be stimulated. But here in IUI, we need uterine contraction to push the sperms towards the tube where fertilization happens. So even difficult IUI, which stimulates uterine contraction towards the uterine tubes, will increase the pregnancy rate. These are the studies. So I don't think we need to go for smooth insemination, always ultrasound guided. In tight pause, or if you suspect some, if always a single IUI will be better, we have already discussed. If you have planned for 2 IUI, first IUI is difficult for you, then second cycle you can plan for ultrasound guide, but not routinely ultrasound guided IUI is needed for all the patients.
So one thing,
even if we irritate the uterus or the whether.
One thing I want to add up. So you people should see how difficult it is to do a IUI with a bladder full, because the patient will be very apprehensive, because you need a bladder where only you can see then visualize the your endocervical canal and other things. If they are overfull, it will be very difficult. So for IVF, it's different. But for IUI, it's very difficult, unless otherwise you find any difficulty in your previous IUI or in any of the procedures that you have done. There is a difficulty in the endocervical canal, or it is difficult in the internal os, or it's very angulated. Then you can do a little bladder partial fill up. That will help to make the endocervical canal little straightened. Even you can use your Cusco speculum to have a little levering out to make it straight, and that will help you much more better. Because IUI is, you just have to cross the internal os and then put it inside. That's all. You don't need much of any ultrasound guidance as it is. There is no better pregnancy rate with ultrasound guided, unless otherwise you have a difficulty, or you have some type of a uterine anomalies like a diadelphys uterus, or it is some type of a uterus. Then you can go for an ultrasound guidance, not as a routine.
Even if we irritate the uterus,
no better benefit also.
Even if we irritate the uterus, so whether the IUI catheter is blood stained or whether soft catheter or hard catheter, it doesn't matter, because implantation will take place after 5 days only.
Right. Any comments on any of these situations which you find during your IUI? all these 5 points? Anybody can answer this. I mean, when you find any of these things, what do you do?
Pardon, sir?
Still,
Yeah, still there are a lot of pregnancies with this type of a difficulty also. When you have a difficulty in visualization of the cervix, then it should be a bladder which is filled, ask her to empty. Sometimes if it is a previous myomectomy or a cesarean scar, it will be pulled up and you may have a difficulty. That time you may need an ultrasound guidance, or you may have to have a tactile, and even you can do you can do an insemination. So it's not a problem. And bleeding from the cervix, if it is there, then it is very difficult to convince the patient for your IUI. Sometimes when you catch hold of the lip, and if there is a bleeding, no need to worry. That's no way affect your outcome. There may be a little release of prostaglandin, which may cause an uterine contractility, but not very bad as you think. But always be gentle for a better comfort. Difficult negotiation, yes, there is a way that you can use your manipulating your Cusco's blade. You can just manipulate it. If it is acutely antiflex, you just depress it so that the canal may be straightened. And if it is very much acutely retroverted, you can even do a little anterior pulling, and then it will get it reflex. So these are all something comes in a very important, no, trauma to the endometrium, nothing will happen. You just go beyond the internal loss and then inseminate. That's sufficient. No need to go to the fundus. And coming out of the sperm, if you're keeping very small milli-equivalents, then it will not have any problem at all.
You can use stillet also.
Yeah. So do it slowly, don't cause too much pain, and make her comfortable so that she can come for more cycles also. Right. Any recommendations for rest after IUI?
Only 10 minutes rest. That also not needed.
Yeah. No. So it's a short rest just to make them happy. That's
no, madam, no rest is not wrong, ma'am. You must advise IUI rest after.
Yeah. 10 minutes rest.
20 minutes. They have given a standard one. 20 minutes you give rest. That will improve. For embryo transfer, there is no need for rest. But for an IUI, there is always a need of rest. 20 minutes you give, that will help that for a better success.
Why the sperm will reach the tubes and within 15 seconds, I think.
No, yeah, within a few seconds it will be reaching.
Reaching.
But they have given all the studies have proved that if you give 20 minutes, there is a better success. That is what it's given for IUI. IUI needs a rest, not for IVF. Even embryo transfer doesn't need any rest.
Well, we'll move on to the luteal support part. Is it routine for all of you to give luteal support after IUI, or you do it in select situations?
Or controlled ovarian stimulation.
Yes,
for controlled ovarian stimulation with the gonadotropin, we give luteal phase support. And if we are using clomiphene for IUI, no need of luteal support. If we are using letrozole, we can give.
Right. Any difference of opinion? And how long would you give it? 2 weeks? Is it good enough?
15 days. 15 days.
Anybody adds other things like HCG and all?
No need for IUI cycles. When you do a control, as rightly pointed out, in the ovarian stimulation, if it is with the gonadotrophins, then you may have more, luteal phase defects, especially in the PCOS and ovulation, where they need a luteal support, which will improve the chances. But no need to add on any other drugs as you do in IVF.
Yeah. So no, not routinely. If you're using gonadotrophins.
If you are giving agonist for trigger, then what is the luteal phase support?
Yeah, then you should increase the dosage. Ideally speaking, you give your 400 means you have to give 600 milligrams of your micronized progesterone. That is the one thing that you have to increase the dosage of your progesterone when you are giving an agonist trigger. If you have more than 3 or 4 follicles, and if you are giving them an agonist trigger, increase the luteal support. The micronized.
And when you start, madam? When you start?
Yeah, immediately after the IUI, yes. When the rupture happens, you have to start.
Okay.
When the rupture happens, you have to start the luteal support.
For all, only for agonist trigger.
No, for all the stimulation you can give. It is always, see, why we are giving a trigger. You tell me why you are giving a trigger. She will anyhow ovulate. Sometimes she may ovulate. But why you are triggering?
For timing.
Yes, tell me.
For timing of IUI.
No. I'm telling you, I'm asking you one question. Why you are giving a trigger, a HCG or a thing? Why you are giving?
For normal cases or IUI
Anybody,
cases?
for your IUI cycles, you all trigger. Why? Otherwise, even with that, will she not ovulate?
Yeah,
Yes.
she will ovulate.
Why you're giving
Mainly if the eggs will not be over mature.
No. You are giving an LH trigger to make the meiotic division of the oocytes to get matured. So that is the one which is very much needed for the LH trigger. So all the HCG, what you're giving, is actually acting like an HCG. HCG, it's acting like an LH to trigger that maturation. So that is very proper if the LH peak is good and it is very much definite. For that only you are giving an HCG trigger. Similarly, when you're triggering the luteal phase, we don't know how far is the oocytes luteal support. So that is why we give empirically for all stimulated, either it could be as oral ovulagens or a gonadotropins, we give them a luteal support to support the corpus luteum to have a better implantation and preparation of the decidua for the implantation. For that only we give. But when you give an agonist, this corpus lutea formation will not be that good as we expect. So that is why we give them a little more of a micronized progesterone, especially when you trigger agonist with an agonist. That's the reason.
Additional point is if you are giving agonist trigger in addition to progesterone, it gives estradiol validate.
Yeah, yes.
Ma'am, I have a difference of opinion. Why give because this HCG has got a high T-off. T-off is more for the HCG, so it will act for 9 days. But madam is asking when we give a agonist trigger, agonist will act only for 24 hours. So after that, there will not be any luteal support. Thus, we have to support the with a more progesterone. But when we give a HCG, we need not to increase the dose of progesterone because HCG has got a high T-off.
Yeah.
And not only that.
That's what I said. When you
not
give an
only
agonist,
that,
you have to
madam.
increase the dosage. Yes, you have to. Yes.
If you give progesterone immediately, that will hamper the tubal motility. That will affect the tubal motility.
No, after the ovulation, you have to give the support. You have to start the luteal phase support. It doesn't mean that you should give only after something. No, nothing like that. When you do ovulation,
after 2 days, I think.
No book says that way. It is after the ovulation, you started luteal support. That's what it's given.
After ovulation, you start.
After ovulation, you have to start. You're not giving with the trigger. You are confirming the ovulation and then only you are starting. That is in a IVF cycle where you will be after the oocyte pickup only you have to do. Similarly, after the ovulation, you will do this. That is the simple thing. Don't start immediately after the trigger. It is after the ovulation. That should be started after the ovulation.
Even if you want to start luteal phase support a little later, even in embryo transfer, not more than 3 days later. But ideally, we all start immediately after IUI or oocyte retrieval. We don't wait for 2 days or 3 days. But studies had concluded not more than 3 days later.
Right. In terms of number of IUIs, we all recommend 3 or 4 IUIs. Anybody who has a difference of opinion or would like to give it for a longer period before going for further evaluation or change in treatment?
Sir, we recommend 3 IUI, but so many times patient themselves will ask for more number of IUI. That time we cannot deny the patient. They tell, keep doing IUI, let us see. Let us do it for 2 more times, 3 more times, let us see. Then we, whatever patient says, we recommend. But otherwise, as a doctor, I prefer only 3 IUIs, not more than 3, because as the successive rate will increase after 3 IUI. So there is no meaning in doing IUI after 3 cycles. If we have done a 3 IUI properly, means ovulation documentation, support of the progesterone, and then number of follicles, everything we have done perfect. 3 IUIs we have given the patient. Then also she's not conceiving, then definitely I recommend IVF. But if patient keep asking for more number of IUI, then I say it's a wish.
Eventually, we end up seeing a lot of patients who have 3 IUIs in 3 different psych centers. I mean, 3. So that's quite common. So
in our center, we have to believe what we have done because we don't know what to happen. So whatever
it's important to counsel the patients about the success rates of IUI, the number of cycles, and also you need to counsel them that the cost of 4 or 5 IVF cycles might actually end up with the same as an IVF cycle. So that's also important for the patients to understand.
And theory
Now,
also, 3 IUIs are equal to 1 IVF. If they don't conceive in 3 IUI, better to go for IVF.
Definitely. So we have a lot of data now about how to optimize the IUI results. Patient selection is important. Give them realistic expectations. Try to get 2 to 3 follicles. Time your IUI properly. Make sure that your semen collection preparation is good. And in selected subgroups, you might benefit from double IUI and give adequate luteal support. Now we'll just wind up the session with a couple of questions about IVF because we don't have too much time. Dr. Kalpana, which would be the patients with male factor infertility where you would recommend the primary clinicians, that means your general obs and gynae clinicians, to don't waste time and send them directly for IVF?
Is actually, honestly speaking, even 1 million total motile count has given pregnancy rate, but it doesn't mean that we have to wait and do a few cycles of IUI, even with 1 million. In our center, if the total motile count is less than 10 million, we straight away take the patient for IVF. That is our protocol. We don't go below that. Obviously, the success rate is going to be very less, and we need not waste time as far as the total motile count is considered.
Right. Any other points, Dr. Shruti?
Sir, less
Obviously,
than 5.
the morphology is also less than 4%. Definitely, the couple is a candidate for FOGSI. In addition to total motile.
Right.
For female factors, advanced endometriosis. For female factors, advanced endometriosis, bilateral tubal block, elderly woman with mild male factor, and then
so that's quite
Poor
important.
ovarian
These are things
reserve.
which are
Poor ovarian
very
reserve,
important. Yeah. So you should not be sitting over patients who are like 38, 39 and doing IUIs for 8, 10 cycles, or with a very low AMH, or somebody who has had 3 surgeries for endometriosis. These should be patients who should be directly sent for IVF and not waste your time on IUI treatment. And male factor, obviously, if you have a persistent ovarian low counts, which is not amenable to medical treatment, definitely you should be looking at IVF. So that concludes the panel. I thank the expert as well as all the participants and the organizers who have given us an opportunity to discuss this very common problems in treatment for infertility. And I wish you all a very good night. Thank you.
Yeah,
And
I also
hopefully
thank
this discussion has opened up the highway for the sperm to reach the egg, and guiding all the people who are listening on the right mode of treatment, so that their particular patients can have happiness and achieve success with whatever treatment we do.
I would like to thank the organizers, PAC committee and adolescent committee with its committee chairperson, Priyanku, Dr. Supriya, under the leadership of Rishikesh Paiser, Madhuri Patel ma'am, Alka Pandi ma'am, and Sampath Kumari ma'am for the conveners, Monica, Dr. Subhashini, and the other conveners, Dr. Bharati, Raghavendra sir, for organizing such a wonderful webinar and giving us a platform to share our knowledge. And also the moderators who brought out all the interesting cases and interesting points which are really needed to be discussed. And I think the delegates would have been taken few important message, which would be really useful for their day-to-day practice. Thank you, everyone.
Thank you. Good night.
Thank you, ma'am. Thank you, Dr. Raghavendra sir and Dr. Abhi Koshi sir, and of course, Dr. Jairani ma'am, for the excellent panel discussion, the moderation. Thank you to all the panelists.
Sorry.
You're muted, I think. Suddenly your voice is not heard.
Hello?
Yeah.
Am I audible, ma'am? Yeah. Yeah, I take this opportunity to thank everyone on behalf of the Public Awareness Committee as well as the Adolescent Committee to having been part of this wonderful webinar today. We will be having our next webinar again with the East Zone on 29th of June on the same thing. Heartfelt thanks to everyone. Bharti ma'am, are you there? Bharti ma'am is not there, I think. Okay, thank you to everyone.
Dr. Supriya.
Yeah, ma'am, please give the vote of thanks. Yeah.
I'm doing some work, but I thank everyone, especially Dr. Raghavendra sir and Dr. Ram Gopal. You both of them did wonderful panel actually. It was continuously I was listening to the panel and the panelists were all very, very good. And Dr. Jairani, you also did very well. And Dr. B. Kalpana, I thank everyone from core of my heart. Thank you so much. And I thank the Corona Remedies, who has really flawlessly done everything, the Zoom platform. Thank you very much. And bye and good night.
Thank you. Thank you, Supriya. Thank you, Ravindra sir. Thank you, Lesser. Thank you. Bye, Kalpana. Shruti, Shobha, everybody is bye. Bye. Rekha, madam, bye.
Bye, madam. Bye, Raghavendra.
Bye.
Bye, sir.